Good evening and welcome. This is the webinar on Pansymposia on small for gestational age fetal growth restriction pregnancies, which is organized by Kanpur Obs Gynae Society in association with Obs Gynae Societies of Gwalior and Indore. On behalf of Jagsonpal Pharmaceuticals Limited, makers of newly launched calcium tablets as NAARI Cal, natural progesterone as Divagest SR 300 and 200 mg sustained release tablets for oral use, Maintane Allylestrenol 5 mg tablets, and LycoRed Preg sachet to prevent pregnancy complications. I am Dr. Deepika Chabra along with my teammates Dr. Arvind Singh and Mr. Amit Saxena. Thank you, Dr. Kiran Sinha, for convening this webinar. Dr. Kiran Sinha is Secretary of Kanpur Obs Gynae Society. She has served in different districts in various hospitals as gynecologist for 37 years. She has been a master trainer of various Government of India projects, and now, post-retirement, she is a practicing Obs Gynae in Kanpur. We thank Obs Gynae Societies of Kanpur, Gwalior, and Indore for organizing this webinar. Also, we are thankful to ICOG for the accreditation of 1 ICOG credit point to all attendees of the webinar today. Welcome to all the faculty present with us today, and a warm welcome to all the attendees. Attendees, please note, you post your queries by text in the Q&A box, which will be answered at the end. Please note, this webinar is brought to you as knowledge sharing initiative by Jagsonpal Medical Services, and this session is streaming on Facebook Live now. The recording will remain on Jagsonpal's YouTube channel for reference and promotion. I will now request Dr. Kiran Sinha, ma'am, please kindly initiate the session.
Thank you, Dr. Deepika. Good evening to one and all. I, Dr. Kiran Sinha, on behalf of Kanpur Obs Gynae Society, welcome you all to this very important long-awaited CME on radiological diagnosis of SGA and FGR babies, followed by case-based panel discussion on management of FGR pregnancies. This COVID pandemic has changed our way of life. We Foxians have made the adversity into opportunity by conducting the webinars and learning new things and updating our knowledge on different and practical issues that is certainly benefiting us and our patients also. Learning has never its end. It is always a beginning. More you learn, more you gain. Now, not taking much of your time, I invite my president, Dr. Nila Mishra. She is a well-known gynecologist and a famous laparoscopic surgeon of Kanpur. She is also current IMA president. She has organized many endoscopy conferences in Foxy. She is invited faculty at many national, international, state level conferences. She has been awarded with Nari Shakti Platinum Icon Award for her contribution to women health. She is always very kind enough to me for always giving me free hand and all the support which I ever needed. Now I request my president, Dr. Nila Mishra, ma'am, for her welcome address and also to introduce our chief guest. Now floor is yours. Kindly go for it, Dr. Nila Mishra.
Thank you, Kiranji, for the kind words. Good evening, everyone. My warm greeting to one and all participating in today's webinar, which is organized by the Jagsonpal Pharmaceutical. Today, we have another very informative and very interesting session, that is Pansymposia on the small for gestational age and fetal growth retardation with Indore and Gwalior Obs Gynae Society. My heartiest welcome to Indore and Gwalior Obs Gynae Society. Friends, fetal growth restriction or intrauterine growth retardation refers to the fetus who does not achieve the expected in utero growth potential due to the genetic or environmental factor. So intrauterine growth restriction is observed in about 24% of the fetuses. Being born small lays the foundation for the short-term and long-term implication for life. Intrauterine or fetal growth restriction describes the pregnancy complication of pathological reduced fetal growth leading to significant perinatal mortality and morbidity and subsequent long-term deficits. Placental insufficiency is the principal cause of the fetal growth retardation, which in turn underlies the chronic undersupply of the oxygen and nutrients to the fetus. The neonatal morbidities associated with the intrauterine growth retardation depend on the timing of the onset of the placental dysfunction and growth restriction and its severity, the gestation at birth of the infant. A better understanding of neonatal morbidities associated with fetal growth retardation will enable every neonatal detection and monitoring and management of the potential adverse outcomes in the newborn period and beyond. Today we have got a galaxy of faculties. I would like to my deepest gratitude to Dr. Kavita Bapat, Vice President at FOXY 2021, who has joined us in spite of her busy schedule, a person who hardly require any introduction, a wonderful academic background, and amount of dynamism she has shown in the FOXY. Madam, my heartful welcome to you, Madam. Madam has passed her MBBS, MS and FIC. She is director of the Bapat Hospital, Indore. She has demonstrated one-day hysterectomy specialist, Vice President-elect FOXY 2021. She is Vice President AMPOG, President Indore Menopausal Society. She is the President of MP Chapter of Vaginal Surgeon, Organizing Secretary AICOG 2021 Indore. She is Secretary MP IAG. She is Executive Member of ISAR and IAG and past Governing Council Member of IOCG. Welcome, Madam. My heart is welcome to you, Madam. It gives me humble pleasure to welcome Chief Patron of Kanpur Obs Gynae Society, Teacher of Teachers, Dr. Meera Agnotri, who is the ex-head of Department of Obs and Gynae, GSVM Medical College, founder of WWCon. She will address the clinical issues on intrauterine growth retardation, which we face in day-to-day practice. Madam is at presently Chairman of Ethics and Research State Medical Council. She is President of WWCon Foundation. She is advisor for Women Health Cell Ministry of Health Government of India. Organized International WWCon first ever conference inaugurated by the President of India and Union Health Minister. She is a recipient of prestigious multiple award, Scott Chancellor's Gold Medal International Award, represented India as a FOXY National Chairperson, 9th FIGO at Montreal, Canada, visiting consultant at Burrell College of Medical Department of Gynecology, Houston, Texas, USA. She has got various national contributions. She's an organizing secretary of All India Congress of Obs and Gynae. She's a chairperson of National FOXY AIDS Committee for 5 years.
Okay.
She has elected a governing council executive member ICOG twice, editorial panel of FOXY Journal in Journal of Obs and Gynae.
It's okay. Neelam, it's okay.
And she has got a recent ICOG Ratna Samman and Gold Plaque 63 AICOG in 2020 at Lucknow, and Best FOXY Focus Award in AICOG 63. She has got a Women Empowerment Award and so on.
That's all. That's it. Thank you very much.
And we have got a faculty of esteemed panelists, Dr. Asha Bakshi, Dr. Reena Kaul-Mattu, Dr. Shashi Bala, Dr. Sangeeta Arya, Dr. Rashi Mishra. Now I'll hand over back to Dr. Kiran Sinha for further proceedings.
That one day your signature becomes your autograph. Now, ma'am, this line fits on you. Now it is time to introduce our guest of honor.
एक बार हो गया ना?
Now I'm highly privileged and honored to introduce my first guest of honor, Dr. Yashodhara Gaur ma'am, who is Professor Unit Head of Gajraja Medical College. She is President MP State Chapter Agoi, Vice President All MP Obs and Gynae Society. She is also Vice President of Medical College Teachers Association. She is faculty of PHFI. She is Master Trainer of HIV, Contraceptive and MTP. She has more than 10 publications to her credit. She is also winner of Best Paper and Best Poster Presentation Award. She has many awards to her credit. To name few of them are Nari Jak Kalyani Award, Gwalior Gaurav Samman Award, Yuva Doctor Award, Best Surgeon Award, Vishis Chikitsak Award. She is invited faculty to various national and state level conferences. Her main area of interest is fetal medicine and high-risk pregnancy. Ma'am, I will request you to bless us with few lines to this webinar to us.
Yes, hello, good evening. Thanks for inviting me and making me a part of this Pansymposia on IUGR. And when the seniors like Dr. Meera Agnotri, Dr. Kavita Bapat, and Dr. Asha Bakshi are there in the symposium, you invited me first for talking. So I must take the blessings from these seniors, Meera Agnotri Madam, Kavita Bapat Madam, and Asha Bakshi Madam. Meera Agnotri Madam, I yesterday met virtually in the UP Congress, the Master Stroke class on cervical cancer eradication, and it was a very good experience. I was not thinking that you will invite me first. Anyways, today's topic IUGR IUGR with ultrasonography and color Doppler. I got trained in ultrasonography by none other than Professor Dr. P.K. Shah sir in Sion Hospital, Mumbai in year 2000. And from that time, I developed my interest in this, and I have developed affection for this ultrasound and this color Doppler. And Dr. Kuldeep Singh very well knows that what are the blessings, what is the knowledge of Shah sir. And Kuldeep Singh sir also came once upon a time in Gwalior for deliberating his lecture. And since then, we are doing this ultrasonography and color Doppler in our hospital, in our day-to-day practice. Everyone is doing nowadays. And it has replaced, it has totally changed the management of the growth retarded fetus. We all know it. There's nothing new in it. And because of this facility and the growth chart, which Dr. Kuldeep Singh is going to tell us, will change our opinion towards the management of the growth retarded fetus. I know, and he is a very good speaker, and he is a very good ultrasonologist, and he will change the opinion of management, how to manage the growth retarded fetus. And what else I say? Dr. Charmila is with us with her in this panel discussion. She is there with her charismatic presence, and she will definitely. It's going to be a very good panel discussion with Dr. Charmila. And with these words, I think. Thank you, Dr. Kiran Sinha, very energetic, very enthusiastic secretary of Kanpur Obs Gynae Society, and Dr. Nila Mishra, president of Kanpur Obs Gynae Society, for making me part of this prestigious Pansymposium, where so many dignitaries are present, where Dr. Kuldeep Singh is deliberating, and where we are having seniors of our Foxy, Dr. Kavita Bapat Didi, Dr. Asha Bakshi Madam, and Madam Meera Agnotri is there. To definitely, she will bless us. Thank you. Thank you, Dr. Kiran Sinha, for making me part of it.
Thank you, Dr. Yashodhara. Madam, kindly stay with us up to the end of the talk so that we will like to have some input from you also. Now I will request Dr. Meera ma'am to kindly bless us with her few words of wisdom. Dr. Meera ma'am.
My dear Kiran and Neelam, great presidents and secretary, along with the Gwalior Society and my own Indore Society, it's really a great honor for me to be present over there. But I don't want to use the word guest. I am not a guest. I am your host. I am your part. I am a part of your family. For all of you, whether it is Kuldeep or Charmila. So guest, I am not a guest. I am neither a host nor a guest, but I am a part of all of you. It's a matter of chance that I am a little senior, you are a little younger, you are brighter, you are stronger. Apart from this, my co-chief guest, as told to me, my
Dr.
dear
Kavita.
Kavita, my blessed younger sister. सुबह शाम मिलने वाले हम लोग. And where is Asha? I can't see her. If I am there in Indore, it is not possible to leave the boundary of Indore without meeting and say bye-bye to either it is Asha or Kavita. जहाँ कहीं भी है हम इनके साथ मिलेंगे. बस इंदौर की बाउंड्री में घुस भर जाएं. उसके बाद we have got lots of programs and talks and talks and talks. And the wonderful conference ahead which they are hosting. हम लोग सब लोग जितने यहाँ पर present हैं उसके लिए बहुत बेताबी से इंतजार कर रहे हैं. और मुझे मालूम है कि it is my second home, so I'll be there. आज के I am just looking at the guest of honor, Dr. Yashodhara and Dr. Veera. I welcome you all. They are very nice, young, dynamic persons, and they are telling that they heard me yesterday. Today also I had few webinars. Yesterday also I had 3. But this webinar is very close to my heart. Whether it when I was a teacher or when I was teaching undergraduate, postgraduate, this is one thing which is the oldest problem. When you enter the MBBS, you enter this problem, and when you come out, you have got still lot many things to add, especially when learned speakers like Kuldeep Singh, a wonderful teacher. Where is Kuldeep? Yes, I heard him, and I always love listening him. 1, 2, 3, 4. The way we talk in the classes, I just don't feel like leaving it. And my dear Charmila, we were there together in one webinar only a couple of days back, and we have enjoyed it. Then our chairpersons, my own Seema Dwivedi and Ruchika Sutpuri, we welcome you all. And a galaxy of the presenters present over here, the learned panelists, including Asha Bakshi, headed by Asha Bakshi, I must say, and Shashi Bala, then Reena Mattu, okay, Reena Mattu, beautiful Reena Mattu, and then Rashi and Sangeeta Arya. I just welcome you all. It's a real pleasure to be with you all through. But I will ask leave because I have to attend a very important meeting and a very important wedding also. So I'm there. And lovely faces. I just don't feel like leaving them. Charmila, you are in OT, I believe. Okay. So with these words, need not to talk about the subject at all. कि 25-30 सालों से आप लोग हमको इसी सब्जेक्ट पर बकबक करते हुए सुन चुके होंगे. Neelam and all the persons present over there. So I need not to talk about this subject, but I know that the learned speakers present over here, they will enlighten the subject, and the panelists who are present over there, they will talk very high about it. And at the end of the program, I personally feel with these panelists, with these moderators, with these chairpersons, and Indore, Gwalior and Kanpur together, this trio will come out with a wonderful trigonal, you see, results, and all of you will go back with wonderful playback messages, and in your practice you are going to add it. I once again welcome, and I am really honored to be a part of it. From the bottom of my heart, I tell you that whenever I am there with you, I really love to be with you, and I don't want to leave you. These smiling, smart, young faces, and our dynamic Kiran and Neelam. इन लोगों को सुबह से मैं कोई ना कोई काम बताती हूँ, और मीटिंग्स एंड मीटिंग्स एंड मीटिंग्स आप लोग सब देख रहे हैं कि कानपुर में जितने लोगों के साथ मिलकर मीटिंग्स करिए, दे आर कमिंग इट वेरी नाइसली. So with these words, I extend this my good wishes once again for a wonderful meeting, for a wonderful conference, and it will be a part of me. I will keep it because it is there on the Facebook also. So I will keep it as a record for me, because I cannot afford to lose the important messages told by these wonderful speakers and the panelists and the moderators. I will love to have it. Thank you very much once again for everybody. For a wonderful meeting.
Thank you, ma'am. Thank you, ma'am.
so much.
Thank you.
आज के लिए छुट्टी दे दीजिए. फिर उसके बाद I will keep it, and I know that you are going to put up very many new things with these strong physics, the moderations, and yes, I want to be there up to the end. But please pardon me today. I'll be with you once again. Okay.
Thank you, ma'am.
Thank you, madam.
Now I will request Dr. Kavita.
Madam Indore, namaskar.
Thank you so much. Thank you so much, Aj, Dr. Neelam and Dr. Kiran. Thank you so much for giving me the chance to share the stage with Meera madam. मेरे तो दिन ही बन गया आज. क्या है? एक तो मुझे chief guest और ऊपर से वो भी मीरा मैडम के पड़ोस पे बिठा के. Really, I am really blessed today. Thank you so much, Kiran and Neelam. I am really happy to have an inspirational Meera madam and her points today about us and everyone. So nice of it. Thank you so much, Meera madam.
Thank you.
And we will be happy.
Yeah, yes. I am there in ICOG.
And you are the person who can guide us for AICOG and everywhere. We need you all the time. So thank you so much.
Thank you, Dr. Kavita Papa.
This topic, which is SGA and FGR, I tell you, whenever you make a list of the topics, these two topics come almost in a top 5 topics of the which is needed, because it can cause a perinatal mortality and a morbidity, and most important, any failure into it leads to the burden to the country. So we are worried about the economic problem of our country. Should save our babies, and we should protect them from the growth retardation as well as the small gestational age. And today you are going to have our own people like Gwalior people, Indore people, and Kanpur. So I'm really happy. And today the moderators are the Charmila and Rishma, and our own Asha Didi, Shashi, Reena, Sangeeta and Rashi, all are there as a panelist, and my own people, the Veera and Yashodhara, as another co-chief guest. I'm so happy. Yashodhara, kitni baar Kavita bola. Thank you so much. Love you for that. So happy. And Seema and Ruchika as a chairperson. And the best part is you are going to listen Kuldeep Singh ji, who is the topmost person and who talks about this subject so depth. And again, once again, thank you, Kanpur Society. Everyone, if I have left someone's name, I'm extremely sorry. But I think I have covered everyone's name. Thank you so much for inviting me, and enjoy this meeting, because this topic is really important. And you are having the best of the panelists, right from Asha Didi and Pam and Reena and everyone. So you will listen the best of the part. Thank you so much for giving me the chance. Thank you, Kiranji and Neelamji. Thank you again.
Thank you, Dr. Kavita Bapat. Please keep this infectious smile always with you. I am really fan of your smile. Thank you so much.
and the best part is the Charmila, the webinar queen, who is the best moderator nowadays in a rating. I think her TPR is going highest, I think, nowadays.
नहीं, आपको पता है, अगर मैं डॉक्टर शर्मिला को कोई वेबिनार अगर मिस करना पड़ता, then I really feel so much that I have lost something.
Yeah, she is also topping the list of.
बड़ी मुश्किल से पकड़ में आई है. इसके पहले मैं PCOD में थी तो ये बिजी थी. कहीं चलिए, ठीक है. Thank you so much. Now my other guest of honor is Dr. Meera Lohiya. She is president of Gwalior Obs Gynae Society. She is consulted at Janak Hospital, secretary of all MP Obs Gynae Society. She is invited faculty in many state and national conferences. With these only few lines, I request Dr. Meera to say few words. Dr. Meera Lohiya, are you there?
Yes. Thank you so much, Dr.
Dr. Divya. Acha, you are there. Okay.
Yes, I am there. Thank you, Dr. Nila Mishra, Dr. Kiran Sinha. Thank you so much for inviting me in among such a galaxy of big stars here. And Dr. Meera Agnotri, Dr. Kavita Bapat, Dr. Asha Bakshi, Dr. Charmila, Dr. Kuldeep. So many brilliant speakers are there. And it really is Kanpur is a home place of mine. मेरा जन्म वहीं पे हुआ था कानपुर में, and I still go every year to Kanpur with कुछ ना कुछ functions. My cousins are there, and Indore तो मुझे लगता है is a second home to me. मतलब they are so close to us कि मजा आ जाता है. Dr. Kavita, Dr. Asha, Dr. Basir, सब लोग they are so close to us. तो सबके, और कानपुर again तो ऐसा लग रहा है घर में ही बैठे हुए हैं सबके बीच में. Thank you so much for giving me this honor. And really the topic that you have chosen is of utmost importance, because every society is talking about it. So we can imagine the importance of it. And this SGA, FGR, the maternal health is key input to the fetal health. We already know. So there are some causes, maternal as well as fetal causes, which are leading to it, and which are speakers. They are so brilliant, Dr. Kuldeep and Dr. Charmila, who is moderating the panel. So they are really well versed and brilliant speakers. I think they will cover the topic very well. So not taking much time, because I think we are already going late. I thank you all once again for giving me this honor. Thank you so much, Kanpur Society.
Thank you, Dr. Meera Loya. Now we move to our first talk, that is on radiological findings of SGA and IGR babies, how to diagnose, and what are the key points while managing these pregnancies. Speaker is Dr. Kuldeep Singh of Delhi. He is in encyclopedia in himself, which all of you will realize once you will listen to him. Now I invite the chairperson of the first talk, Dr. Seema Dwivedi. Dr. Seema Dwivedi, she is professor in Medical College, GSBM Medical College. Her main field of interest is ultrasound and high-risk pregnancy. Second chairperson is Dr. Ruchika Sutpuri, who is fetal medicine expert, is consultant at Regency Hospital, Kanpur. She has delivered many lectures on role of fetal medicine in Obs and Gynae. Her main field of interest is fetal echocardiography, neurosonography, prenatal diagnostic and invasive procedure, and her vision is to spread awareness regarding unmet needs of newborn. Now I request Dr. Seema Dwivedi to introduce Dr. Kuldeep Singh. Please, Dr. Seema Dwivedi, introduce Dr. Kuldeep Singh in short, so that we should listen more to Dr. Kuldeep Singh. Dr. Seema, please go ahead.
Thank you, Kiran ma'am, for your benevolence, for giving me the proud privilege to introduce the great stalwart of ultrasound, master trainer with more than 300 lectures in national and international platform in more than a dozen countries, with 4 awards, 3 gold medals, and 16 books on ultrasound, now running successfully a Sono school, which organizes various training programs in ultrasound. So we are honored to have you in our webinar.
Thank you. Thank you so much, ma'am. Thank you for the kind introduction. Thank you. Thank you so much, ma'am. This is indeed an honor. I'm from Lucknow, so thank you all for inviting me. I'd like to thank Dr. Meera. Thank you, Dr. Kavita. Thank you so much. It's been seeing all of you. We've been into all these things. Dr. Nila Mishra, thank you so much. Dr. Kiran, thank you so much for inviting me. And thank you all esteemed panelists. It's going to be like a continuation. I'm going to be telling you about the 2D and the color Doppler for diagnosis, prognostication, and management of FGR and SGA pregnancies. There are plenty of overlaps. There are plenty of things which we need to be discreetly clear about, and that's what we're going to discuss it over the span of my talk. At the end of it, once my talk is through, there's going to be a small questionnaire of 10-15 questions. That is just for your self thing, so that we understand and we don't make a mistake. An SGA fetus is a fetus with a weight below the 10th percentile for gestational age. The fetus is otherwise healthy and has a relatively low risk for perinatal morbidity and mortality. You need to be very, very clear of the definition of what an SGA is. Where do you and when do you call it FGR? An FGR fetus is also a small fetus, but to define it, it's a weight below the 3rd percentile for gestational age, or its weight below the 10th percentile along with Doppler abnormalities, either in the uteroplacental circuit or in the feto-placental circuit. Developments in Doppler of the maternal and fetal circulation, fetal heart rate analysis, biophysical profile. Never say that this thing is now defunct. There'll be places when you'll not be able to get hold of a color Doppler. You need to be looking at your biophysical parameters as well. They've improved the diagnosis of both FGR and SGA. SGA pregnancies often and usually exhibit normal fetal Doppler. FGR, because of a placental disease, they exhibit maternal and fetal Doppler abnormalities. So you have isolated fetal smallness, poorer prognosis. We need to be looking at whether we're looking at an FGR or an SGA, because the managements, the strategies are going to be different. The protocol for looking in for an FGR is, first and foremost, you need to be identifying whether this fetus is small or not. Once you figured out it's a small fetus, now do you label it FGR or you label it SGA? Fetal growth restriction, small for gestational age. Then whether it's an early versus a late. What are the parameters that you would like to look in for a fetal follow-up and stage-based management protocol? That's what Dr. Kiran had also said, that we're going to be running slow so that we can understand each and everything. So rather than we get into some sort of confusion, the confusions have to be removed today in the talk and during the panel. How do you identify whether this fetus is small? First and foremost, establish the gestational age. Estimate the fetal weight, that's step 2. Step 3 is calculating the weight percentile. You all have to get into habit of, every machine has it, to plot it on a graph. Determination of gestational age, that's the first step. If you're not sure of if this baby is supposed to be 28 weeks, is it supposed to be 30 weeks and it's 28? It's supposed to be 28 and is it 28? Or it's supposed to be 32 and it's 28? So you need to be careful. Whatever piece of paper that patient has in the first trimester, usually between 6 and 8 weeks, that is the most important for dating the pregnancy. Calculation from LMP, not always reliable because of all these factors. For a dating scan, you're going to be looking at in the first trimester. How are you going to be knowing what all to include and what to exclude? If your crown rump length measurement is within 5 days of the LMP dating that's coming up, that means you can use the LMP. If it's more than that or less than that, whatever the difference is, more than 5 days, you need to be looking in for the ultrasound age. Make a note of it. You cannot be having a different EDD or a different dating in your 8-week scan, then your 12-week scan, and then your 18-week scan. First and foremost, just highlight it on the first page of the patient information. A transvaginal scan can see a gestational sac as early as 4.5 weeks. You're looking at the cavity over there. If it was there in the cavity, that would have been a pseudo-gestational sac. You're looking at an intradecidual sign, that is the gestational sac implanted in the anterior endometrium. That's the intradecidual sign, the first sign that you're looking in for that there is an intrauterine pregnancy. Gestational sac, yolk sac, and you're looking at cardiac activity. That's the embryo. You need to be careful. Do not measure the yolk sac along with it. That is why nowadays dating is not done at 6 weeks. They prefer anything more around 7 to 8 or 7 to 9 weeks, so that the fetus is also straight and you know the yolk sac is also a little farther away. You're not going to make the mistake of measuring the yolk sac in this. You're going to be measuring from one end to the other. That's the ideal time for dating. But if somebody's come earlier, you can always start your dating, but be careful of knowing your landmarks. Amniotic sac. You're looking at the fetus over there. You're looking at cardiac activity, umbilical cord. That's the chorionic cavity which has the yolk sac. That's the omphalomesenteric duct over there. All perfectly normal. Reproducible, accurate method. After 12 weeks, because of the flexion or because of the extension, there could be a confusion. Every few millimeters makes a difference of a few days. So be very, very careful. After 12 weeks, if they haven't come to you for the first time, start using the BPD. What you're measuring is the longest fetal diameter. Never trace for the crown rump length. That's a TAL, that's a total arch length. From 6 weeks to 9.5 weeks, the crown rump length grows at about a millimeter a day. Accuracy, plus minus 3 days when you're looking at 7 to 10 weeks, plus minus 5 days when you're looking at 10 to 14 weeks. Just you do not need to remember this formula which we used to earlier on. Your machine is going to calculate, measure the crown rump length, and it will give you the weeks of gestation you're looking at. After 12 weeks, be careful, start using the biparietal diameter. Be careful that you're measuring it from outer to outer. It has to be continuous. You can't have that the neck is not here, then you're taking an oblique lie and you're going to be making a mistake. So the crown and the rump have to be absolutely clearly defined. Measure it correctly so that you get a proper crown rump length. You need to be, if you're doing your NT scan and the patient has come to you for the first time, be careful. The fetus should occupy between 60 to 98% of the screen for getting a proper magnification and a measurement of crown rump length. Transvaginal scan, wealth of information that you're going to be getting. You're looking at the skull properly, choroid plexus, spine, you're looking at the ribs over there, you're looking at limbs nicely. You're going to make sure that the fetus is not in an extended or reflex position. Take the measurement from crown to the rump length with proper magnification. Coming on to the second trimester, if you're looking at dating prior to 20 weeks is reliable if the fetal biometry is within 10 days. Then you're going to be using the LMP, otherwise be careful. I'm not saying they came to you at 7 or 8 weeks and now again you're doing a dating. Dating has to be done once and you know it, that it has to follow from there. But if they come to you for the first time, you're going to be looking at this way. After 20 weeks, the BPD difference could be 12 to 15 days. It could be 3 weeks if you're looking at around 30 to 32 weeks. So you need to be careful. Even if any piece of paper, any picture, any notes says that they've got a scan done and this was it, it's much better using that because that would make a difference of 4 or 5 days or a week rather than of 3 weeks at this stage. The parameters that you're going to be using, BPD and head circumference for the cranium, the femur length and the abdominal circumference. We're talking about dating and then we'll come on to the FGRs and the SGAs. BPD, HC, AC, and FL. There has to be a proper methodology to measure them. For estimating the fetal weight, you could be using the Shepherd, the Hadlock, the Indian charts. I normally prefer using all 4 parameters, the BPD, head circumference, femur length, and the abdominal circumference to calculate the fetal weight. Of all the fetuses with a weight below the 10th percentile, 70% are small for gestational age. No additional risk of perinatal morbidity and mortality. They are true SGAs or constitutionally small. Remaining 30% are FGRs. How do you do the measurements? In the second trimester, you're going to be taking from an outer to the inner portion is how you're going to be taking the biparietal diameter. The section you're supposed to be looking at the cranium carefully. The thalamus pointing posteriorly, anteriorly is the CSP or the cavum septum pellucidum. Outer table to the inner portion, outer to the outer is the OFD, and completely enveloping the fetal skull is going to be the head perimeter measurement. You could have a rounded shape, you could have an oval shape. Oval shape would be dolichocephaly. A rounded shape would be brachycephaly. So the BPD could go a little haywire, but the head circumference is going to be unchanged irrespective of the shape. So they're not affected in FGR until very late stages. So you can use that. Sometimes when you're using the femur length, depends on the patient's height, depends on the father's height. That's why it could make a little change. So towards the end of pregnancy, nowadays they're using head perimeter as a good indicator. Abdominal circumference, single best parameter for the detection of FGR. You're looking at an abdominal circumference below the 5th percentile, you need to be watchful. Related to liver size, highest sensitivity and the greatest negative predictive value, you need to be measuring them 2 weeks apart. There is no point they come today and then you again call them back after 2 days. There's a particular way of measuring that I'm going to highlight. It's at the level of hepatic vein between fetal respirations. An increase in abdominal circumference of less than 10 millimeter in 2 weeks has a very high sensitivity and a specificity. You're going to be carefully measuring the abdominal perimeter. These are the landmarks. You're looking at liver. You're going to be looking at umbilical vein entering. This J has to be there. You're going to be looking at that. Try it out. It's very, very simple. The kidneys are not supposed to be seen. You can see the suprarenals. You can see the fetal stomach. That is how you're going to be measuring in between fetal respiration. If the section is high or low, there could be sources of error. You compress the abdomen too much, that could also give a false impression. Or you're taking an oblique section, you could again be making a mistake. You need to be measuring from shadow to shadow is where you're going to be measuring the femur. Do not measure from the trochanter onwards. Try and measure it from the shadow to the shadow. That's the best way of measuring, so that towards the end you do not include the distal femoral epiphysis. Charting, always try and see that patient, see where exactly is or what the numbers you've given the patient. Always feed the values again so that you can plot it out and see where is the centile coming on. I'm going to show you a few examples. Head circumference. You can have it either on the 10th or the 5th percentile. 50th percentile is the center one, 95th. So you're looking at normal head circumference during various weeks of gestation. Abdominal circumference was going fine, and by 30-32 weeks, it's coming closer to the 5th percentile. If you're going to see it for the first time, you do not know what previously happened, so it has to be jotted out properly. The fetal weight also has to be jotted out. That is how you're going to differentiate whether this FGR is starting on. You're looking at an abdominal circumference which right from the beginning has been on the lower side. FGR, SGAs, you need to realize what is the potential. If the baby's potential is on the 95th percentile and is coming here, you need to be cautious. If it always has been here as not falling down, you're still comfortable. It could be an SGA or a constitutionally small fetus. That is how you're going to be carefully evaluating your growth charts. Try it out. You'll be able to do that comfortably. FGR versus SGA, that's how I started off with. SGA is a weight below the 10th percentile. FGR is weight below the 3rd or below the 10th with abnormal Doppler. Types of FGR, we can have type 1 or an early onset before 32 weeks. Easy to identify, difficult to manage. Difficult to manage because of prematurity. They suffer chronic hypoxia. They are fighters. They have a better tolerance for hypoxia. 20 to 30%, and plenty of times you're going to be looking at pre-eclampsia in these fetuses. You come on to the next portion is late onset FGR or type 2 after 32 weeks. Difficult to identify because you're not sure of what you're looking at. Everything was going smooth and all of a sudden you find there is a problem. From the acute phase to going on to the super acute or the severe phase, in type 1 or in early onset, it takes few weeks, few days. In late onset, it can happen within few hours. So everything was fine yesterday when she had come to, and today you figure out that 50% of unexplained near-term stillbirths are because of late onset FGR, which goes unidentified. They're not fighters, poor tolerance to hypoxia, and most of the FGRs are the late onset varieties. They do not have pre-eclampsia or blood pressure hassles, so you need to be watchful, and I'm going to be telling you the markers that you're going to be looking at. The same thing in a tabulated form. Accuracy of Doppler velocimetry in conjunction with 2D. Never do a color Doppler only. 2D measurements, very necessary, and it's an indispensable component. You cannot say if you do not have 3D, 4D, it's absolutely fine. But you nowadays in your practice need a 2D and a color Doppler for sure. Exclude fetal anomalies, evaluate fetal size, quantify LycoRed, evaluate the biophysical parameters, assess the placenta, cord, and the cervix. What is the objective? You're trying to figure out to detect and assess the fetus at risk for death or damage in utero, immediate fetal health, what's the present scenario, what the future are we expecting. We need to be watchful. That is where we need to be smart. It's not that this problem has happened and then we start thinking it retrospectively. Then we've not done any good to the patient. We have these three things which we're going to be looking at in Doppler to identify vascular bed resistance, see the uterine and the umbilical, fetal adaptation, middle cerebral artery, cardiac decompensation, ductus phenosis, and umbilical vein. Be careful of reading this complete slide. Under physiological conditions, 60 to 70% of umbilical venous blood is distributed to the liver, remainder to the heart, and you should be clear on the remainder to the heart goes via the ductus phenosis. With chronic hypoxemia, this proportion is modulated. Now oxygenated blood has to reach, so there's going to be more and more blood flow going via the ductus phenosis to the baby. It is going to be bypassing the liver to reach the heart and to the brain, the most vital organ. Early stage in fetal adaptation, increase blood flow in the ductus phenosis so that we can protect the brain, the heart, and the adrenals. There's a central redistribution of blood flow, that's the brain sparing, and reduced flow to the peripheral and placental circulations. Uterine arteries reflect trophoblastic invasion. In a low-risk mother, it predicts a hypertensive disorder. In a high-risk mother, it predicts perinatal morbidity and mortality. We have the first trimester invasion of spiral arteries, 4 to 12. Early second trimester invasion of radial arteries, up to 22 weeks. That is why we need to be careful. If you need to start your ASA, it's more sensitive if started before 16 weeks. That is why we carefully are doing it in our NT scan, evaluation of the right and the left main uterine arteries. We take out a mean, and usually that value should be less than 2.5. It's more than 2.5. What are we going to be interpreting? I'm going to be letting you know. Various things that are going to be discussed. So I'm not going to be looking at that, but this is how you're going to be looking in for pre-eclampsia planning. Indications of uterine artery Doppler, plenty. Nowadays, usually in all NT scans, we are doing the uterine arteries, the main uterine artery, both sides. We need to be careful where are we insonating it. The moment it crosses the iliac vessels is where you're going to be insonating your main uterine artery, right side and left side. You're looking at, this is the vein, this is the artery. You're looking at aliasing, you're looking at, that's the vein portion, uterine artery, right and left side. It's absolutely simple. don't feel that, yes, it's difficult and we'll not be able to get it. Obviously, the first time is going to be difficult. You need to follow two dictums. One, the eyes are going to see what the mind knows. That's what we're going to be all discussing. And if anyone can do it, you definitely can do it. So that's how you're going to be insonating. You're looking at systolic flow. You're looking at diastolic flow. No notches seen over there. Almost half of diastolic flow as systole. You know it's absolutely normal. Increased impedance, meaning if you're looking at a mean uterine artery PI of more than 2.5, or you can plot it on whatever charts you are, you know it identifies about 50% those are going to develop pre-eclampsia, better in predicting severe rather than mild. Same thing for identifying about 30% of those who are going to develop FGR, better in predicting severe rather than mild FGR. That's how important uterine arteries are. Effect of medication basically increases the end diastolic velocity, the resistance lowers obviously, and it's going to improve the uteroplacental circulation. A notch in your NT scan is absolutely normal, so don't think as high impedance. It's always good to do a manual trace rather than a semi-automatic or an automatic trace, unless and until you got a nice clean waveform. Problem happens is the machine is going to read up all the noise also, and you're unnecessarily going to get a wrong value. Whenever in doubt, do a manual trace. You need to be having lots of patience while doing ultrasonography, as is the case with any medical procedure. This is how it starts off. You're looking at a notch. We've stopped looking at deep notches, shallow notches, placental side, non-placental side. You're looking at that's a notch. You're going to be calculating the PI. This is very early in pregnancy, which is normal. Gradually, the diastolic flow increases. The notch becomes shallow. The notch disappears. Plenty of diastolic flow. That is how it progresses. How important is it? If you're looking at the likelihood ratio of normal or abnormal, for FGR, increases 5 times, pre-eclampsia 10 times, perinatal death 3 times when you're looking at an abnormal. Does not mean that if it's normal, none of these can happen. It can, but we're going to be carefully visualizing the fetoplacental circuit. You can use the uterine artery as a screening procedure, but not the umbilical artery, because when 70% of the placental tertiary villi are affected, they show changes in the umbilical artery. But when 40% are affected, FGR starts off. So you need to be looking at very carefully that it's not as a screening procedure. If by any mistake you've done an umbilical artery at 12 weeks, don't label this as an absent. This is absolutely normal for that stage. With increasing gestation, the diastolic flow gets better and better. You're going to be insonating a free loop of cord, not near the origin, not near the insertion. Book says you should have 3 readings, 3 times do it, and then you're going to be looking at, I know that's practically not possible. So try and take a nice good reading. This is the spectral flow that you're looking at, the velocities. You should be getting a nice clear cut systolic and a diastolic flow. Calculate the SD ratio, RI or the PI, whichever chart you are following. When you're looking at a progression of a problem, you'll first figure out that it's normal. Then you'll have decreased in diastolic velocity, absent in diastolic velocity, reversed in diastolic velocity. Positive predictive value, 92%. It precedes your NST changes by 3 days. With due respect to the biophysical profile in NST, you need to be following them up very closely with your Dopplers. Normal flow, reduction, you need to be careful. Absent, you need to be very, very careful. When you're looking at reversal, you need to be looking at all the parameters. It's a very good fetal surveillance modality. It reduces the need for fetal intervention, improves neonatal outcomes, and predicts perinatal outcome. Absent or a reversed end diastolic velocity unlikely to occur within 7 to 10 days when you're looking at a normal waveform. So you need to be watchful. If it's normal, you know catastrophe is not going to happen in the coming 7 to 10 days. Increased number of tertiary stem villi, there's going to be a problem. There's going to be uteroplacental insufficiency, and an absent or a reversed is an ominous finding. Carefully looking for your middle cerebral arteries. It reflects cerebral flow. What is normal, what is abnormal, I'm going to explain that to you. Always try and locate a vessel first on the color. You can see these pulsations. That's the thalamus over there. That's where the middle cerebral artery. Anterior cerebral, posterior cerebral, spreading out from the thalamus is your middle cerebral artery. Absolutely easy, and you can just insonate it over here to get a proper waveform. Now what happens is, you know the three indices, all these three indices tell you about impedance or resistance to flow. So these values are high, meaning the impedance is high, meaning the blood flow is less. Now this is normal flow. If you're going to be looking at abnormal or there's going to be a brain sparing, means there has to be more blood flow going to the brain. So the diastolic flow is going to increase. So the PI value is going to reduce. Flow increasing, the resistance has to go down. With increasing in hypoxia, there's going to be brain edema. Now again, the resistance is going to increase. So what I normally follow is a PI of more than 1 is regarded as normal. When the PI comes to less than 1, meaning there's brain sparing starting. With increase in hypoxia and things giving way, there's going to be again a PI going more than 1. That's the best way to follow it up. That's how you're going to be understanding things. But if in your practice you're getting brain edema, meaning we haven't really hit the nail on the head, we need to be carefully evaluating that the baby should have been delivered a little before. That is abnormal waveform, brain sparing, because the end diastolic flow is increased and the PI or the pulsatility index is less than 1. How do you interpret fetal arterial Doppler? You're looking at fetal redistribution. Within 2 weeks, there's going to be problems in the biophysical, abnormal venous Dopplers, suboptimal CTG. A growth-restricted fetus would usually develop an abnormal umbilical artery waveform before developing fetal arterial redistribution. Very, very important is cerebroplacental ratio. How do you calculate that? The middle cerebral artery PI divided by the umbilical artery PI. Most sensitive marker for redistribution. It can be abnormal even when the umbilical and the middle cerebral artery are normal, meaning there's more blood flow going to the brain has started, less flow in the umbilical artery, but it's giving you changes in the CPR. You need to be watchful. CPR of less than 1 is the early sign of redistribution and a very sensitive marker in late onset FGRs. Late onset, if you're looking at an abnormal CPR, higher incidence of fetal distress, lower cord pH, increased admission rate to the NICU. Descending is flow to the abdominal viscera and lower limbs. There's going to be less blood flow in the descending aorta, so that more reaches the vital organ. That's a cranial preferential redistribution. That's where you're going to be insonating. The moment it crosses the diaphragm, you're going to be. The moment you're looking at very less flow, meaning nature is trying to send more towards the brain, the heart, and the adrenals. What's the role of venous Dopplers? Especially when it's less than 30 weeks in severely FGRs in a setting of chronic placental insufficiency. You need to prolong the pregnancy so that the steroids can be given so that we can have proper lung maturation. It's an additional non-invasive information telling you the functional capacity of the fetal heart so that we know when is the optimal time. Every day gained is going to be useful. Venous Doppler scanning, usually when you're looking at an absent or a reverse end diastolic flow in the umbilical artery, is strongly recommended. I normally do the venous flow even when it is normal so that we have a complete flow on that. Ductus Phenosis, it reflects acidosis. This is the site. You're going to be looking at the umbilical cord entering, umbilical vein, umbilical part of the portal vein. There's a branch which goes off to the liver. There's another one which goes straight to the inferior vena cava. Where you're going to be finding this aliasing is the cheat code to figure out your ductus venosus. There's one branch going to the liver, the other one going on to the other side is your ductus venosus. Extremely easy to get. There is nothing to worry. You just need to get into a habit of focusing where to look in for your ductus venosus. You're looking at an M sort of a pattern. You're looking at an M pattern, ventricular systole, ventricular diastole, atrial systole. This is what is most important. As long as you're forward flow, you're comfortable. Absent or reversed, acidosis setting in, the cord pH is going to be quite low. Why is it so important? Because via the ductus venosus, there's a separate jet going via the inferior vena cava to the right atrium. It does not enter the right ventricle, but via the foramen ovale, the purest form of blood, left atrium, left ventricle, goes to the brain. M sort of a pattern for your ductus venosus flow. So if your end diastolic flow is reducing, you know trouble is starting. Absent or reversal, you need to be very, very watchful. Umbilical vein, again, it reflects myocardial function. And when you're looking at a double pulsatile pattern. When you're looking at a problem in the umbilical artery, gradually your ductus venosus A wave is going to reduce. You're going to have reversal of end diastolic flow in your umbilical artery. Reversed in ductus venosus. Pulsatile umbilical vein, constriction of cerebral circulation, death within 96 hours. Should we deliver here so that we get a live baby? No. We should have delivered the moment this thing was starting off, because after this, the APGAR could be going wrong, things could be really going bad, and we need to be visualizing that. To really help us in that, we nowadays visualizing the aortic isthmus. Again, it's not that we earlier had ductus venosus and now we've come up with something separate. It's just that it's always helpful. Ductus venosus reflects the right heart. Aortic isthmus reflects the left heart, and that's the first to go back. Not telling you all these technical details, but yes, there are three watersheds over here. Left portal vein, foramen ovale, and the aortic isthmus, extremely important. You can have it in the longitudinal view, or you can have it in the three vessel trachea view. You're looking at the last portion before it enters the ductus arteriosus or joins on. You're going to be looking at that's the aortic isthmus. In the triple vessel view, the midpoint is PAS. So the last portion in the pulmonary artery is the ductus arteriosus. The last portion before it joins in this V is the aortic isthmus. Again, it's quite simple. You need to get into a habit of it. Aortic isthmus. You're looking at that Y over there. That Y portion, the moment it's entering over here, this is the ductal arch, this is the aortic arch. This Y portion is what is the end portion of the aortic isthmus. And you're going to be getting forward flow. The moment you're looking at reversal of flow, meaning nature is trying to steal away even the ductus arteriosus flow, even the deoxygenated, so that it can give the brain a little bit of nutrition and oxygen. You need to carry out serial Doppler investigation. Abnormal venous Doppler means deterioration in the fetal condition. Preterm growth restricted fetuses, elevated umbilical artery, overall perinatal mortality of 5.6. Doubles, when you're looking at end diastolic velocity, absent. From here, it goes almost 6 times if you're looking at abnormal venous Doppler. So you need to be watchful from here only. Reverse flow in the umbilical artery, pathological waveforms in the venous system are best predictors of severe fetal distress. That's how it happens. Growth lag, increase in cerebral blood flow, redistribution starting off less than the 5th percentile, and you're looking at problems here of reversal of ductus phenosis and absent or a reversed end-diastolic flow in the umbilical artery. When do you really call it quits? That the action points. If you're looking at less than 32 weeks, the moment you're finding changes here, you need to be delivering. More than 32 weeks, the moment you're looking at an abnormal CPR, you need to be watchful, otherwise they can land up into sudden IUDs. When to deliver? Gestational age, very important to decide that. The neonatal care available at your site dictates when to deliver. Less than 32 weeks, every day gained is useful. Every week gained, outcome improves by 40%. Venous Dopplers help in delaying the delivery. You need to be watchful. The biometry has to be done 2 weeks apart. Do not unnecessarily do it every 2 days or every 4 days. It's useless. Frequency is dictated by severity of growth restriction, gestational age when we're talking about Doppler. 2 to 3 weeks if mild, and I'll just explain you with the classification how that's going to be done. A live fetus or intact survivability. You need to be weighing the risk of intrauterine compromise weighed against the potential risk for iatrogenic premature delivery. If I deliver too soon, I'll be in trouble. If I really tell the patient to keep in the fetus inside for long, might be again I'll be in trouble. That's where you need to be smart. It's not the survival that's important, it's the intact. Live, rollicking, healthy baby is what we're supposed to be giving this. Last few slides, very carefully how we're going to be managing these, not in terms of treatment, but in terms of your ultrasounds. We have all these Doppler indices. Middle cerebral artery is a surrogate marker of hypoxia. Early sign of fetal hypoxia as it depicts the brain sparing, which is protective mechanism for more blood supply. Again, be very, very careful and start looking at your cerebroplacental ratio. Most sensitive marker for redistribution. It's a very sensitive marker in late onset FGRs. Less than 1 is the earliest sign of redistribution. Ductus phenosis, strongest single Doppler parameter. It can lead to, or it predicts when you're going to be looking in for fetal death, especially in early onset. CPR for late onset, ductus phenosis for early onset. Absent or a reversed velocity, you're going to be looking at an IUFD within 48 to 72 hours. Be very watchful. Pulsatile ductus phenosis, gross abnormality. Aortic Isthmus, a very good balance between the brain and the systemic vasculature. Normal is forward flow. If you're looking at reversal of flow, it's a marker for poor neurological outcome, meaning the brain is having less oxygen and it has to steal from the pulmonary artery, which is deoxygenated blood, to supply to the brain. So definitely you're going to be looking at a poor neurological outcome. It precedes the ductus phenosis abnormalities by 1 week. So this is left heart, ductus phenosis, the right heart. When it's going to start failing, you're going to be looking at abnormalities. Last 5 to 6 slides explaining you what all are you going to be doing for stage-based classification and management. What do you do for your SGAs? When you're looking at less than the 10th percentile, but the Doppler values are normal. Follow them up fortnightly. Labor induction at 40 weeks. They're not always constitutionally small, so be watchful towards the end. Stage 1 FGR, which is mild placental insufficiency. You're looking at uterine artery, umbilical artery, middle cerebral artery, or CPR, mild abnormalities. Weekly monitoring has to be done. Labor induction beyond 37 weeks acceptable, but you need to be looking in for fetal distress. Stage 2 FGR, severe placental. You're looking at an absent end diastolic velocity or a reversal in the aortic isthmus. You need to be monitoring them twice a week. Delivery to be recommended if you've crossed 34 weeks with these findings. Stage 3 FGR, advanced fetal deterioration. Now is when the deterioration is happening. You're looking at a reverse end diastolic flow in your umbilical artery. Ductus Phenosis is starting to go bad. You need to monitor them every day or every second day. Delivery by cesarean if you crossed 30 weeks. High suspicion of fetal acidosis, high risk of fetal death when you're looking at FHR deceleration or a pulsatile ductus venosus. 12 to 24 hours if you're really looking in for. Do your aortic isthmus also very, very careful at this stage. Looking for so that whatever time you can gain, you'll be looking at a tertiary care center delivery. Take home messages. There are many methods for fetal surveillance, but you need to be judiciously using them. When to start depends on the prevailing materno-fetal clinical situation. Patient counseling, very important. Risk to the fetus for continued intrauterine existence has to be evaluated prior. Too detailed, too frequent antenatal testing, it does not mean that you're looking at improved fetal outcomes. Abnormal test results, not to be used in isolation, but a part of the entire clinical scenario. Primarily, goal is to identify fetuses at risk for injury and death. When do you need to be intervening and doing a timely delivery so that we can prevent progression to stillbirth? Last carry-home message, management of FGR and the decision to deliver is an optimum balance between minimizing fetal injury or death versus risk of iatrogenic prematurity. We'll have a short questionnaire of barely 3-4 minutes so that you can just have it for your self-assessment. Are all SGA fetuses FGR? Definitely not. Are all FGR fetuses SGA? Yes, definitely they are SGAs. You're looking at on the 8th percentile normal Doppler, that is an SGA. But if you're looking at 2nd percentile with a normal Doppler, that is FGR, less than the 3rd percentile. Less than the 10th with abnormal Doppler is again FGR. Ductus venosus flow reflects the right heart. In brain sparing, the PI value, that is the impedance, is going to go low so that there is more blood flow going to the brain. Ductus venosus flow pattern is M-shaped. Uterine artery, always the main uterine artery has to be insonated. All these 3 indices tell us about resistance to flow. All these things are important. Dating, interval growth, and Dopplers for diagnosing FGR. Diastolic flow in the umbilical artery with gestation increases because the resistance goes down. This is not reversal of flow. This is basically a Doppler inward. Absent end diastolic flow. A cerebellar transverse diameter of 17 millimeters from 14 to 22 weeks. In millimeters, a cerebellar transverse diameter means that many weeks of gestation. So that is how you're going to be following it up. Somebody is conceived in lactational amenorrhea, not sure of her dates, has come to you in the 2nd trimester the first time. That's how you're going to be following it up. So friends, you need to be very watchful. Your 1st trimester scan is the key for looking in for SGAs and FGRs. Plot them from your 2nd trimester onwards. Now, why do I need to do it? It gives you wealth of information. Whenever you're doing your growth scan, see where exactly is the head circumference, the BPD, the fetal weight, the abdominal circumference, the femur length following, so that we are sure of. Use your uterine arteries in your 11 to 14 weeks. If required, in your anomaly scan, looking for the fetoplacental circuit, looking at the umbilical artery, the middle cerebral artery, the ductus phenosis, wherever required, looking for the aortic isthmus, so that you all can be giving a live, healthy, crying baby to the parents rather than a live baby but not doing so well. And we figure out that there were neurological problems after 2 years or at 10 years, and we feel sorry for ourselves. Thank you. Thank you so much.
Thank you, Dr. Kuldeep Singh. You have spoken from your heart. That has added flavor to your talk, Dr. Kuldeep. It is always a pleasure to listen to you.
Thank you so much, ma'am.
Okay. So many things have been cleared. At least now we are able to see what to see, how to see, when to see, and when to take actions. At least this much has been cleared by your talk. Now we move to case-based panel discussion on management of FGR pregnancies. Today we have a great moderator with us, Dr. Charmila. Her way of moderation is excellent. Dr. Charmila is director of Aditi Hospital and Parvati Fertility Center, Trichy. She is governing council member 21 to 23. Past secretary of Trichy Society. She has won 5 trophies of Foxy as her secretary. President of Menstrual Hygiene Management. She was organizing secretary of UA Foxy in 2013. She is winner of Mr. and Mrs. N.A. Pandit Award for her excellent work in women empowerment. She has also been awarded Dr. Nehru Hansotia Prize for her great work on women empowerment. She is editor of Handbook on Recurrent Pregnancy Loss and ICOG Campus on High Risk Pregnancies. And the co-moderator is Dr. Reshma Nigam, who is senior consultant at Kanpur. She has a special training in IVF from Sir Gangaram Hospital under the leadership of Dr. Abha Majumdar. Her main interest is high-risk pregnancy. She has held many posts in Kanpur. At present, she is treasurer of the society. Now, Dr. Reshma, I will like to invite your panelist of today's talk.
So honored to introduce Asha Bakshi. She is organizing chairperson of upcoming AICOG 2021 Door. She is lead consultant at Dr. Asha Bakshi Fertility Center in association with Motherhood Hospital Indore. She is Vice President-elect 2022 West Zone Foxy. She is Joint Secretary SR 2021. She is founder chairperson MP, IAG and SR. Apart from organizing so many national conferences, her many credits goes first to her, that is, hello? That is ICSI, TISA, ICSI Babies, Micro Tessie, ICSI Babies or MP. She is recipient of Dr. Kumud Tamaskar Award also. Dr. Asha Bakshi ma'am, please welcome.
Hello ma'am.
Yes, Dr. Shashi Bala, she is secretary Gwalior Obs Gynae Society.
Reshma, patapat karo, der ho rahi hai.
She is working as a specialist in Health and Family Welfare Department in Gwalior for more. Yes. Dr. Shashi Bala, welcome.
Thank you. Thank you.
Dr. Reena Kaul Mattu is she's Dr. Reena Kaul Mattu. She is Director Reena Deep Women and Child Care. She is Joint Academic Secretary Cox. Her special interest in gynae, endoscopy, infertility and ultrasound. Dr. Sangeeta Arya, Associated Professor and Head of the Department, GAMC Banda. She is co-editor of Cox. Her special interest in minimally invasive surgeries and pregnancy. Dr. Rashi Mishra. She is IVF specialist and director of Shivani Hospital and IVF Center Kanpur and director of Kusum IVF Chhindwara. Her areas of interest are fertility, endoscopic surgery, and andrology and embryology. Welcome to all the panelists. I request Dr. Charmila, very charming and sweet Dr. Charmila, to go ahead with the panel. Dr. Charmila, please.
Yeah, thank you. Thank you, Rishmi. Thank you so much for that introduction. And I'm really grateful to Dr. Kiran ma'am for the opportunity. And it's being in a prestigious society like Kanpur and doing a moderation for a topic which has been excellently covered by Dr. Kuldeep. I don't think there'll be any doubts in anybody's mind when they're managing an FGR pregnancy. But let's make it into a discussion where we want the inputs from the panelists so that we know what is the practice which they are doing, and we'll get a consensus at the end of it, because sir has given the proper excellent protocol which you need to follow to screen for FGR as well as monitor, but we need to be very careful when we are managing such women, because as sir said, you need to do this so that you help out the women folk, and so that we reduce the neonatal morbidity and mortality, which is a part of FGR pregnancies. So I would like to welcome the esteemed panelists, Dr. Asha Bakshi, Dr. Shashibala ma'am, Dr. Reena, Dr. Sangeeta Arya, Dr. Rashi, and I think, ma'am, who's the fourth panelist?
Rashi ke baad Dr. Ruchika Sutpuri.
Okay, Dr. Ruchika. Okay.
Yeah.
So I'm just quoting what the Society for Maternal and Fetal Medicine says about FGR. It occurs in almost 10% of pregnancies, and that sir said so clearly in his talk. And is only second to prematurity in causing infant morbidity and mortality. And that's why you need your screening protocols to be in place when you're managing any woman when she comes pregnant. Because in addition to the significant perinatal impact which it has, FGR also will have an impact on long-term health outcomes when they become adults. So we need to manage them with the utmost care even when they are in utero. So the first case, she's a 30-year-old. She's a primigravida. Occasionally, she had irregular cycles. When she was married for almost 1.5 years and she didn't conceive, she went for ovulation induction and she came with a urine pregnancy test positive. Her vitals were fine. BMI was 30. Hypothyroid since 2 years, and she's been on thyroxine. All her routine antenatal investigations are normal, and we did a GCT also. Ultrasound showed a 7-week fetus, which corresponded to dates. As Dr. Kuldeep sir said so clearly, you need to date your pregnancy when she comes in the first trimester. So actually, she's very worried because her sister had a small baby, which was delivered by cesarean. And south of the country, cesarean is a great insult to the family. That's what they feel. So they had a baby by cesarean, and the baby needed NICU care for almost a month, and they had to spend so much money for that. So she wants to know how to avoid having a small baby like her sister, and she needs to know what are the tests she needs to come and when she needs to come, the frequency of her visits. Does she need to come more? So if Asha ma'am is there, I will put the question to her. Do you think that all pregnant women will need a risk assessment for FGR at the first booking? And what are the risk factors you would look for in your assessment? If you say yes. Ma'am, you need to unmute yourself. Asha ma'am, please unmute yourself.
I think this is the most important thing at the booking visit. I think we should really go in details if she's primary, but it's very important to know how she has performed in the past, whether there is any history of IUGR or in the family, any risk of severe pre-eclampsia or eclampsia. If she's suffering from recurrent miscarriages, whether she's IVF pregnancy, whether this is a frozen embryo transfer pregnancy, what is her age, whether she's overweight or underweight, then what is her social background like, is she a smoker, and whether she has a history of high blood pressure, diabetes, renal impairment, EPLA. So all those factors are very, very important. So when a patient comes to us for the booking visit, it is at this particular time we should make note of everything. And once we know this, then we can keep her in mind that this is a high risk case and this is a low risk case. And whether it is high risk or low risk, I think every patient we have to look for fetal growth retardation, because other things, most of the things can be tackled, but this is something which comes by surprise. So instead, and it has its own perinatal morbidity and mortality association.
And the family also will not accept it if you say the baby was fine for a point of time and suddenly you say now it's growth restricted. So that's why you need to counsel them even when they come regarding the risk factors. And as madam said so correctly, you need to do all the risk factors before you label her as low risk or at a high risk category. This is the green top guidelines regarding the minor and the major risk factors. We don't have a risk factor assessment chart for our country, but we have much more reasons for having SGA and FGR babies. So I think we need to, as Asha ma'am had already helped us in one study, I think as she's going to become a vice president, I'll put my asking for help even now, that you should put your time for a data collection on IUGR in our country. And one day we should come out with the risk factors which we need to evaluate, because Gestosis score is doing so well for hypertensive disorders. And we don't want a blood test, a scan, which our women will not be able to spend and which is so reluctant. So if you have a scoring by just history taking, it will be a very great help to our country. So, but this is the green top guidelines by NICE for major risk factors as well as the minor risk factor. Thank you, Asha ma'am. So, ma'am, Sashibala ma'am, suppose she comes under the low risk category. She has got no risk factors at all. How are you going to call her for her assessment later in her pregnancy? How are you going to follow her up?
Follow up in late pregnancy? Initially,
no, ma'am. We have just categorized now, as Asha ma'am said, that she comes into the low risk category. Absolutely no risk factors. She has no risk factors. So how are you going to assess her if she's going to go for FGR or not? Because there are no risk factors to tell you what to do now.
Now, since there are no risk factors, we'll treat her as a normal antenatal case. We'll go in for every antenatal visit, we take her BMI, her weight, her sugar, and we should see, ignorance is not always bliss. If she's not right now, if she's not high risk, she might go into late SGR also. So we have to keep in mind, and at 22 weeks, we'll have to go in for an ultrasound. And sir has said very clearly, sometimes it doesn't show initially, but later on, if she goes into that, we should be well prepared. So we'll ask first trimester serum markers, we'll ask her for, we should also be on the lookout for pre-eclampsia, since she's a primey and she was on hypothyroid and she had irregular cycles also. So we have to see for the most consistent factors. And then second trimester, once she enters into that, then we have to go in for other markers like HCG, and she might go into hypertension. So these are the early pointers.
Let me ask you, like in your practice, do you do an NT scan for all your pregnant patients?
Yes.
You do an NT scan. So at that time, you can ask a sonologist to do a uterine artery Doppler, right? So that you get one thing of your this thing, and you'll know like whether she's got any resistance in the uterine artery, so that you have something to follow up on.
Yes, we have to remind them, because they take it in their stride. They just do the NT scan and they send the patient back to us until and unless we tell them.
You have to counsel, you have to tell your sonologist to follow up with the uterine artery Doppler also when you're when they are doing the NT scan. And when you're doing an anomaly scan, we can always do the Dopplers again just to check.
That time we are more careful, but in NT scan, we only go in for NT scan. But nowadays, since the patients are almost more than 30 years, most primaries, they are coming out to us. So this needs to be mandatory. We go in for that.
And suppose lucky enough, she's undergone a double marker, you will know with your PAPA. If it's going to be low, you know that she's going to go for a major risk factor now. PAPA decreasing in the first trimester markers tells you that she's going to the major risk category. So you need to really follow her up for FGR. And suppose she develops hypertension in the middle, before you go for the regular checkup, like an anomaly scan, which you said at 20 weeks, if she develops hypertension before that, another major risk factor is coming into the picture. That's why in your low risk category, you need, if you are going to do an NT scan, please go for a double marker also. If you have a suspicion, as Sashi ma'am said, that suppose she's a BMI is more than 30, which is a minor risk factor, and suppose she's got a hypothyroid, a metabolic disease, it's better if you do a double marker, and you will have your PAPA, which will tell you if it's low, that you need to go for a proper surveillance protocol for such a patient, because she gets into the high risk category. So that is one thing. Thank you, Sashi ma'am, for that. So as Sashi ma'am said, an anomaly scan, and you at that time, you can always ask for a uterine artery Doppler, and a serial symphysiofundal height estimation clinically still has its role. Don't think that just because only ultrasound is there, the obstetrician will have to leave their traditional way of checking a lady. So a symphysiofundal height estimation, and make it serial. Do not make it like a single measurement, miss the other thing, ask your nurse to see and you not seeing is not acceptable, because you can always pick up FGR if you do a proper symphysiofundal height estimation. And biometry at 32 weeks is acceptable for a low risk patient, because you need to know whether the baby is growing well. and an umbilical artery Doppler, because that's a best surveillance tool, which will also help you to find out whether she's going into the high risk category of FGR. Reena ma'am, can I ask you, like, suppose she's got one major risk factor, that is the major risk factors, I'll just go back. Suppose she's age above 40, or she's a person who's having a chronic hypertensive disease, has had heavy bleeding in the first trimester. All this makes her into the major category. So what will you do for such a patient? How will your surveillance start? When will you start your surveillance? Reena, Dr. Reena?
Because she has one major risk factor, it is recommended according to the Green Top guidelines, which you said, that we should start early surveillance of Doppler and serial
when will you start?
From 26 to 28 weeks onwards. So even if her uterine artery Doppler at 20 to 24 weeks is normal.
She's got one major risk factor. Will you go for a uterine artery Doppler for her? Do you think it's necessary?
It is not necessary, but since we are doing a TIFA at 20 to 24 in all patients, and it is and in my cases, we are usually combining even NT scan as well as TIFA scans with uterine artery Doppler screening in all patients. So irrespective of whether it turns out to be normal or abnormal, because she has one major risk factor, we have to do her serial monitoring with ultrasound and Doppler from 26 to 28 weeks onwards. Yes. So that would include the fetal biometry as well as assessment with umbilical artery Dopplers.
Perfect. That's what this patient also would have undergone if she had a major risk factor. As you said, surveillance starts at 26 to 28 weeks of gestation, and you need to do a serial measurement of the fetal size, and the fetal well-being needs to be assessed with the umbilical artery Doppler. Dr. Sangeeta, suppose she has got only minor factors. This patient actually has got two minor factors. That is, she's a nullipara. BMI is on the higher side. So she's got two risk factors, minor two risk factors. So how will you deal with such a patient?
Ma'am,
major risk factor.
She has got minor risk factors, but the thing is that she has BMI of 30. That makes her prone for, she was worried for cesarean section. Itself, this obesity can lead her later on to the cesarean section.
No, I want to know, like, how will you do a fetal surveillance? How will you plan your surveillance when you see a minor factor?
I'll be doing the dual markers at NTNB scan and the dual markers, and I'll be seeing the PAPE as you have earlier mentioned it, and then I do the surveillance later on with the this TIFA I do.
Dr. Ma'am, let me interrupt. Dr. Reena said that because there's a major risk factor, she will start the surveillance at 26 to 28 weeks of pregnancy. Yes. This person has got a minor risk factor. So when will you start your surveillance for a person with a minor risk factor?
From the 32 weeks onwards, I'll be
little later. Yes.
32 weeks I'll be following, and with the symphysial fundal height I'll be looking at first, and with the serial monitoring, if it looks so, then I'll be moving forward for the other ultrasound markers.
Yes, ma'am. As you said, you are already doing your double markers and your anomaly scans, and you combine your uterine artery Doppler along with that. But you will start your surveillance little later because she's got two minor factors compared to the major factors which Dr. Reena had. So 3 or more minor risk factors, that's what the NICE guidelines tell us. You need to do a uterine artery Doppler at 20 to 24 weeks of gestation when there are minor risk factors. In a major risk factor, you don't even need a uterine artery Doppler. Irrespective of whatever it shows, your surveillance needs to start at 26 to 28 weeks of gestation. The significance of uterine artery Doppler at 20 to 24 weeks is, we need to remember that high risk populations, it does not have much of predictive value. So you need not even add on, suppose she's not on a uterine artery Doppler. And suppose you have got one abnormal uterine artery Doppler and subsequently find that it's normalizing, does not mean that she's not at high risk. She becomes a high risk even with one value of an abnormal uterine Doppler. And suppose you get an abnormal uterine Doppler at 20 to 24 weeks, she moves on into the major risk category. From the minor risk category, she moves on to the major risk category. And if a normal uterine artery Doppler is seen, they do not usually require any serial measurements. You can actually take them as normal patients who are not going for FGR. But suppose they develop hypertension or something like an antepartum hemorrhage, then the surveillance needs to become much more intense. And as Dr. Kuldeep sir said, there's one point about doing a third trimester fetal size estimation as well as an umbilical artery Doppler, just to check out whether she goes for late onset IUGR, FGR. So suppose she gets suppose in your anomaly scan or something, you pick up an echogenic bowel, and or in your double marker she had a low PAPE, she moves on to the major risk category with your testing. Without your risk factors, when these two happen, she moves on into the major risk category. Second trimester markers do not have, downscreen markers do not have much of predictive accuracy for finding out about a SGA neonate. So, Sangeeta, Dr. Sangeeta, can you summarize for me for a minor risk factor? For risk factors, Dr. Sangeeta.
For the minor cases? Huh?
No, I just want you to summarize regarding the risk factors, doctor.
If one major risk factor is there, we have done the assessment, the dual marker as well as the uterine artery Doppler at 24 to 26 weeks. If any of the one major risk factor is there, then we have to do the surveillance. We have to start the surveillance from the 26 to 28 weeks onwards, and we have to look further for the serial assessment. If 3 or more minor risk factors with abnormal uterine Doppler has been there, we have to assess it as a high risk case. Then we have to do the surveillance accordingly. But if minor risk factors are there and uterine artery Doppler shows there is no abnormality, then we can be near about sure that there is no, as such, there is no panic for the surveillance to be started from the 26 to 28 weeks. We can start it later on. But anyhow, in the umbilical artery, we see the two factors, along with this scanning, we get the echogenic bowel or umbilical artery Doppler is abnormal, then we consider this to be having a high risk, this patient, and this needs further surveillance from the 26-28 weeks onwards.
Actually, it's a uterine artery Doppler. Umbilical artery Doppler comes in a surveillance.
Uterine artery Doppler, yeah.
Okay. Dr. Rashi, can you tell me the significance of symphysis fundal height estimation for assessment for risk of FGR?
Symphysiofundal height is more specific than abdominal examination. Symphysiofundal height measurement is main examination for obstetrician, the traditional way you told. Lots of Indian females are very reluctant for ultrasound, and also there is non-availability of ultrasound in peripheral areas. So there is an importance for symphysiofundal height measurement. It is basically after 24 weeks of pregnancy. It can be measured from top of the uterus to the pubic symphysis height in centimeter is equal to the weeks of gestation. If the difference is more than 3, then it is significant. And as you told, serial measurement is important. If you are doing it single measurement, it is not so important. Serial measurement, if the growth like height is not rising, not increasing, stable, or and it is important that it should be done in vertex position only. And if the lady is obese, multiple pregnancy, oligo and polyhydramnios, in these cases, symphysiofundal height has a limited role. So in these cases, we have to go for ultrasound. And for routine antenatal visits, symphysiofundal height, serial symphysiofundal height has its role.
Thank you, Rashi. Thank you so much. You made it so clear. So let's move on to the second case. That was a person who never had anything. We just wanted to assess whether she has got any risk factors. This person is a 27-year-old primey. She also had irregular cycles, married since 10 months, was diagnosed with a biconvex uterus. Correct dating scan was done. First trimester NT scan was normal. Uterine artery Doppler done at that time was actually showing a normal flow. Anomaly scan also was quite fine. The anatomy was fine and the biometry was also good. On antenatal examination, 32 weeks, there was a suspicion of a growth lag. Ultrasound done showed a growth lag and the percentile was less than 10%. What to do now? Asha ma'am, is this FGR and how do you diagnose FGR?
Yes, this is small for dates. And especially if it is less than 10 percentile, then we can call it small for dates. Now, small for dates can be of two types. One are constitutionally small and the other is the growth retardation. So almost 40% of these babies are growth retarded. And it's very important to diagnose them. And about definition, this has been a definition since long time, about 10%. But then many people are trying to redefine it, and they're trying to check everything like abdominal circumference, the estimated fetal weight, and that they are even saying that even if it is less than 3 percentile, then also it is important. And then people are taking functional score also, that is they are taking the Doppler values also at the same time, and they are trying to correlate everything because that will give you a better definition. So still there is no clear consensus about the definition, though traditionally we all accept the 10 centile, the less definition, when weight or AC is less than 10 centile.
SMF has come out in 2020 with the definition now, and they've said you can take either the estimated fetal weight or the abdominal circumference. When it's the less than the 10th percentile, you take it as you said, it may be SGA or FGR, and they include both estimated fetal weight as well as AC. But ACOG takes only estimated fetal weight. So there is a discrepancy in the guidelines also. When we took when I went through almost the 6 guidelines of different countries, all had different values, but they were all unanimous on one thing, the 10th centile. They were very sure about that. And many were taking only estimated fetal weight, but SMF has now said you need to take the abdominal circumference also, which is less than the 10th percentile as a FGR baby. So this is the classification, as you said, ma'am, if it can be an early onset or a late onset. This is the classification which they use now, and it will be very severe when it happens in an early onset type, because that's because of severe placental insufficiency, hypertensive disorders, sometimes genetic disorders, maternal hypertension or Doppler abnormalities even before that. Late onset is a milder clinical course, but as Dr. Kuldeep said, you have to be very careful. The late onset ones are the ones you will miss, and they may go for unexpected stillbirths. That's why you have to be very careful even for evaluation of late onset FGR, because you miss the other ones. You will be doing a proper surveillance, but many of us will miss that late onset FGR, and the mother can have a stillbirth. And when you have a severe FGR, as Asha ma'am said, suppose it's a 3rd percentile, you have to be very, very careful because it's a more severe form of FGR. So actually the nomenclature now has been changed. They say you should not use IUGR at all. And SMF has now said, and there's nothing like a symmetric or asymmetric FGR. It does not help in determining the prognosis. You need to evaluate all of them with a proper single protocol which will help any FGR baby. Sashibala ma'am, what do you think is the optimum method of diagnosing an FGR, and what are the parameters you think should be monitored? Dr. Kuldeep sir has already said in his talk, but would like to know what we do clinically. Sashibala ma'am?
Yeah. Since we are discussing this case number 2, it is a case of late onset of IUGR. So,
yes, ma'am.
So, by all means, ultrasound is the mainstay, and it is real helpful for all of us, and we have to make it mandatory. So, biometry measurements we can see, and as he said, we have to see the discrepancy between actual and expected date. Abdominal circumference you have to see, and that small for gestational is defined as birth weight below 10 percentile, as you said. So diagnosis will be done by that. So factors which we need to monitor, we have to see the growth, we have to see the uterine artery Doppler, and of course amniotic fluid volume. Umbilical artery. And we also see AFI also for placental perfusion.
Because everybody used to make fun of offset.
Mentioned.
I wanted to specifically want you to talk on amniotic fluid volume, because people make fun of us when we say that Lyca went down and I'm taking her for a delivery, and they keep on saying this is all just to take an unnecessary cesarean and all that. But so we need to know that amniotic fluid volume also plays a major part in the diagnosis. Yes, ma'am. Sashibala ma'am. Dr. Sashibala ma'am, Dr. Reena wants to say something. Dr. Reena?
There is a science. So now, yes.
Yes, thank you, ma'am. Dr. Reena.
I just wanted to emphasize that in this patient at 32 weeks, she was first diagnosed as weight less than 10th centile. That makes her small for gestational age. but it raises a suspicion of FGR, but we can never diagnose any patient as FGR only on basis of one ultrasound, especially when the Dopplers and other things and LycoRed is normal. So we have to follow at least after 2 to 3 weeks another ultrasound, growth scan, biometry and Doppler.
So Dr. Reena, we are coming to that. Actually, I was asking Sashi ma'am regarding how she will be monitoring. That's all. We have not come to the basics of that. We are just going into that. So Dr. Poonam is not there. Dr. Ruchika is there. So yes. I wanted to, Dr. Kuldeep has already told us very clearly, but I would just like to tell us in the point for an obstetrician so that we know what to do when you have a person who is having a growth restricted baby. Yes.
Yes, we have to do the biometry. In biometry, the 4 main parameters are the biparietal diameter and the head circumference, abdominal circumference, and the femoral length. These are the 4 main parameters. And out of these, abdominal circumference is the single best parameter, and it is more sensitive and affected first in cases of fetal growth restriction. And abdominal circumference less than 10 centile is suggestive of it can either be SGA or it can be fetal growth restriction. So we have to add on Dopplers along with it. If the Dopplers are normal, then we will categorize it as SGA. And if Dopplers are normal, then definitely FGR.
This is what Dr. Reena was saying. You need to do a serial assessment. A single measurement is not enough. And you need to do the fetal size evaluation, as you said, with the BPD, the abdominal circumference, the ratio, as well as the fetal weight. And sequential growth assessment is better than single measurements. That's what they're emphasizing again and again. And as Dr. Reena said, a recommended interval is 3 weeks for a biometry. There's no point in doing it earlier because you're not going to pick up anything extra just by doing it earlier. That's what one thing which obstetricians tend to do. That is when they are worried that the baby is going for growth restriction, they will keep on asking like baby's weight and the biometry and all that. Does not make any sense. Next, your surveillance will go on with your umbilical artery Doppler. You have to switch over to the other modality where you need to know whether the baby is becoming compromised or not, because you need to deliver her before the baby goes for a problem. So this is Dr. Ruchika, umbilical artery.
I just want to add one thing, ma'am. For diagnosis, we need 3 weeks interval, but once it has been diagnosed, then 2 weekly ultrasound for the assessment would be required.
Biometric, yes.
Biometry and Doppler.
Yeah, once you're diagnosed and you know it's going for a problem, you have to go for an earlier biometry. 2 weeks will be an ideal.
2 weeks.
So umbilical artery Doppler should be the primary surveillance tool. And suppose it's normal, is it okay if we repeat after 14 days, or do you want to do it earlier? Umbilical artery Doppler. Suppose the Doppler shows normal flow. Will you do a surveillance after 1 week or 2 weeks? Which do you think is okay?
2 weeks.
2 weeks. After 2 weeks,
okay.
Will be fine.
Okay. So we do it after 2 weeks. So one measurement done, and you call her after 3 weeks, and you confirm. Then you do a 2 weekly biometry along with a 2 weekly Doppler if the Dopplers are normal.
Basically, we have to see the trend, ma'am. How is the Dopplers they are going, whether they are uprising or falling down. So the trend is more important rather than one measurement.
So the goals of surveillance is you have to avoid a stillbirth, but you also have to avoid an iatrogenic preterm delivery. That's why your surveillance has to be pakka. And if possible, you can avoid the long-term adverse health outcomes, because if you keep on doing a surveillance and you're not delivering in the proper time, that also is going to cause more problems. Dr. Reena,
preterm is better than stillbirth.
Yes, anytime. That's why, but preterm babies tend to have more of morbidity, ma'am. So as much as possible, try to save them in utero. And when it becomes very difficult for the baby to be to survive, you need to take out. That's why your surveillance has to be on point. You cannot afford to let go at any point of time. That's what the surveillance mechanism has to be put into place. Dr. Reena, you wanted to say something, but
I wanted to say that previously we used to say that once the umbilical artery Doppler is normal, there is no need of doing further vessels. But these days they are saying that we should do both umbilical and middle cerebral artery, because sometimes it may so happen that umbilical is normal, but the middle cerebral artery is already showing the brain sparing effect.
Yes, ma'am. That we are coming to at the end of it. That question I will ask you, because I put it at the end for you, because we tend to, because when you have a risk factor, you're very careful. You put your surveillance and protocol in place and you tell her to come and all that. But when it's normal and you let go and you miss and there's a stillbirth, That's the worst thing which can happen. So you cannot go by guidelines sometimes. As Dr. Ruchika put so clearly, you need to see how the trend goes. You cannot put it does not like every size fits all. That policy will never happen. Every lady is different, or every baby is different. So that your experience and your instinct has to come. That's why you have to be very clear in your surveillance protocol before you start the management plan for such women. Dr. Reena, like any other than ultrasound, anything else can you do for fetal surveillance? Because Dr. Kuldeep has put us the picture that only ultrasound. Anything else we can do?
We can do the CTG or the biophysical profile also.
And movements.
We can ask the patient to record her movements by the
daily
tick
fetal movement
test,
counts.
the daily fetal movement counts, or the Cardiff rule of 10.
Actually, I want to know from the panelists, what is that method you tell your mothers to follow? Because everybody has got different methods of asking mothers to check for fetal kick counts.
What I tell my patients is that you say you begin at around 9 a.m. after you have done your morning course and your breakfast, and you start, you take a piece of paper and pencil, you do whatever you're doing, and whenever you have a fetal movement, whatever type it is, because they tell it like it is jumping or kicking or whatever it is, you record it as one.
No, I just want to know the time you ask is 9 o'clock. Any specific reason?
Evening. No, it's not it's specific, but it is a convenient time. Like after doing the morning course and everything, that she's gone for bathing.
Shall I ask
bedtime.
Asha ma'am, what do you think is the ideal time to ask your mother?
I have a different policy. What I do is I tell them that, are you getting good movements? And they say yes. Are they more than 10? They say yes. So what I say that whenever you are feeling, and usually if you are feeling the same thing, then it's okay. But the day you feel that it has not been so active as every day, then please lie down for 2 hours. That time, don't do anything. Take a piece of paper and pencil. And
so, madam, in your this thing, the mother has to watch for the entire day then?
No, only for 2. Means if she's feeling that I'm okay, then that's fine, because she knows that movements are there.
Okay.
But if she
so you want to find out the change which she perceives.
On that particular day, I want her to lie down for 2 hours and jot down every movement that she gets. And if in 2 hours she's getting 10 movements, then she can be reassured.
Okay. Rashi, what's your
I think bedtime is better.
I used to advise, like, if the patient is like a high risk case for like IUGR, we are following that patient for FGR. In these cases, I advise them after breakfast, lie down for 1 hour, left lateral position, and note down whether you are feeling movement or not, after lunch also and after dinner also.
I'm sorry for interrupting. Asha ma'am said that the difference in the perception which she has. That's what madam wanted as this thing. Dr. Reena said 10 movements. So you take us 10 movements in 2 hours? That's your policy?
Yes, ma'am.
In the morning, you do. Dr. Ruchika, what is your policy?
2 hours, 6 movements. 2 hours, 6 movements.
So 2 hours, 6 movements is enough for Dr. Sashi ma'am? Dr. Sashi ma'am says
1 hour, 10 moments.
1 hour, 10
1 hour,
moments.
2 moments at bedtime. At
1
bedtime.
hour, 2 moments at bedtime. Sangeeta, Dr. Sangeeta?
Ma'am, I usually ask. 1 hour, 10 movement, 10.
10 movement, okay. Very vigorous baby. Dr. Sangeeta?
Ma'am, usually the patient is not able to tell the fetal movement counts when she is very busy. Usually, whenever I tell her, whichever is the convenient time, at like after the lunch, if she is free.
It's like Asha ma'am's protocol.
Yes,
you tell her like whenever she feels okay.
In 1 hour, 2 to 3
I just wanted some short this thing, because I want to know like how each part of the country is doing. And I've asked all the panelists. Okay. So there's like 2 people who are saying there's a perception which changes. You do it in the morning or the convenient time. So there are different methods of doing, but actually there's one study which has come from, I think, Norway, where they said you need to do it in the evening. Evening time is the best time, because the mother is more relaxed, and they found out that the baby movements are much more in the evening compared to the morning time. So they always say, ask the mother to check for the, and as all of you said, every method which you said were all correct, because it can be through 3 movements in 1 hour, it can be 10 movements in 12 hours, even 12 hours which is working. That is also good enough. And as Asha ma'am and Dr. Reena, they were saying like the perception. Suppose she feels she's feeling good movements one day, and the next day she's feeling of loss, then you need to be more careful. So because all this is very important, Because what is there is in Norway, when they did a study, when they told the mother, suppose you have a reduction in fetal movements, you come to the hospital at once, and they found out it resulted in a substantial reduction in stillbirths. That's why the maternal perception of fetal movements, if you tell them very clearly and they are asked to come when they've got a presentation with the decreased fetal movements, and when they come within 24 hours and within that 48 hours time, and you have already identified IUGR, they said they've reduced the stillbirth rate. That's why I was asking how each of us are asking our mothers to do. And this is Dr. Reena's question. Dr. Reena, please sum up for us.
So, fetal kick counting, you want me to summarize that there are many methods. There are many methods of doing it. According to the Cardiff rule of 10, we ask them to count 10 movements and leave it. Once she counts 10, she can leave counting for the rest of the day. And we tell her that if she does not count 10 in 12 hours for 2 consecutive days, then she should report. Or if she does not, then there is another method in which we say DFMC, we record 1 hour in the morning, 1 hour after breakfast, 1 hour after lunch, and 1 hour after dinner. And
will she not become stressed out if you tell her to do so many things?
This is what is written in books, but what I do mainly is that for any low risk patient where there is no problem, as a routine, I tell them, ask them, do you have normal fetal movements? Do you feel any change? And if she says that there is any change, or if she is high risk, then only I ask her to monitor it.
Okay. Thank you. Yeah, you summarized well. Thank you. So this is what this, and Dr. Sangeeta, what about our CTGs? When does CTG come into the surveillance protocol? Dr. Sangeeta?
CTG is a good resource for the surveillance of the fetus. If we are assessing that, if we are suspecting that this is the FGR and we have to follow this baby further, the CTG is a very good surveillance method. It can detect acidemia before getting the baby compromised. We can detect the babies having hypoxia or acidemia.
So if you have a baby which is reactive, we know we have ruled out fetal acidemia at that point of time. That's why that needs to be very carefully said. You can, Dr. Kuldeep said, if you have a normal umbilical artery Doppler, you can be happy for a week.
Yes,
but with your CTG, you cannot be happy for a week. It is that only at that point of time. And when you have got repeated decelerations, it can be fetal hypoxia, or it can be due to cord compressions because of the oligohydramnios. And please remember, non-reactive NST can be sometimes very much high false positivity rate is there. So, so you need further evaluation. And presence of accelerations will confirm reactivity. It has to be done after a meal. Please remember, the mother should not be hypoglycemic. If she's there, the baby will not move much, and it may give a false positive result. So you need to ask the mother to eat and then come for the test. And if it's reactive, we know that there's absence of fetal acidemia at that point of time. And they've said one thing about FGR monitoring with CTG. Actually, the heart rate variation is one of the best markers to find out hypoxia. And for that, we cannot do the visual examination. We need to do the computerized analysis because that will give us a better picture of the reactivity which is happening. The short-term variability as well as the long-term variability is very clearly picked up in a computerized analysis compared to the visual inspection and checking out and writing out that accelerations were there. A computer's analysis is much better for picking up the minor factors which are happening before the baby goes for a compromise. But please remember, NST cannot predict severity or deterioration in the condition of the baby. And regarding the SMF guidelines, when will you do CTG is, suppose there's an uncomplicated, just there's a reduction in the Doppler flows, there's no absence or reversal, you can do a weekly CTG testing. But suppose she goes to the higher variety of either absent or reversal of the end diastolic flow, and you need to admit her sometimes, and you need to do a higher rate of testing for fetal hypoxia. So the predictive value of each test is contraction stresses we don't do nowadays because we know that itself can cause an acute fetal compromise. High false positivity is there. NST is also having a high false positivity rate. Very difficult to pick up in high risk mothers like diabetic and IUGR babies. And there's something like a biophysical profile which says got a very, very low false negative rate. And it's very good to pick up hypoxia. So I would like to have the opinion of the panelists. First, Dr. Rashi, on biophysical profile. How do you think it's useful?
Biophysical profile is NST along with 4 real-time USG observation for 30 minutes. It includes, along with NST, breathing movement, fetal tone, breathing movement should be more than one or one in for 30 seconds in 30 minutes observation, and
do you think
more
our
than
sonologist will do all this if you ask him?
No.
Modified
Most of them won't do.
biophysical.
Then
They'll
modified
just, yeah.
biophysical profile is NST plus AFI. Because of this only this modified biophysical profile came. If the score is more than 8, it is good. If the score is less than 4, like sequence of like first reactivity goes, then breathing movement goes, then tone, then there is loss of movements. Like this it goes. We can if the reactivity is reactivity is not there, and if fetus is still breathing, we can judge it is in this phase. Like this it can help us to predict the outcome.
Yeah, but the thing is, biophysical profile is first very cumbersome to do. The mother is not going to lie down for half an hour with an ultrasound probe there.
Not practical.
Yes.
She's going to scream in the middle. And then the other thing is, even if you check out and you find out the score is fine, still it can deteriorate very rapidly sometimes, and stillbirths can happen even if you've got a good biophysical profile. So the point is, it has to be an add-on procedure, just to add on to your other values, so that you know the trend of what's happening to the baby, and it should not be done as a standalone method to just check out whether the baby is doing or fine, and you cannot be reassured that the baby is going to do perfectly the next day, even if you have a good biophysical profile today. And regarding the amniotic fluid assessment, Dr. Rashi?
Amniotic fluid assessment, if signal pocket is less than 1, it is decreased, and volume assessment is important.
You think AFI is good, or the single deepest pocket is good enough? Which do you think is better?
I feel AFI.
Amniotic fluid index, AFI. Yes. Dr. Reena, she wants
single pocket.
Single pocket. Asha, ma'am?
4 pockets.
Asha? 4 pockets. Sangeeta?
Single pocket.
5.
4 pockets, AFI.
5
Dr. Sashi, ma'am?
5 pockets we take. At least 5 pockets should be there. Yeah.
Dr. Ruchika?
Single pocket.
Do you think is okay?
Single pocket is better than 4 quadrant.
Because they say when you do a 4 pocket technique, they say it's not very good in assessing, and if you have a single pocket, which gives a much better, that's what the latest thing is. But we know, like in the antibiotics, it will again change. Now at this point of time, it is a single pocket. We don't know what's going to happen with the guidelines after a year, but now it is a single pocket. But whatever you're comfortable with, I think that's a measurement you should take, because we cannot keep on relying on Western guidelines for our management.
So if we get 5 pockets, excuse me, if we get 5 pockets, then we wait for 1 pocket, single pocket. We can just sit back.
You just check 1 pocket, and if it has a good volume, more than 1 centimeter, you know that the baby is doing well. You don't need to go for all the 4 packets. That's what they mean. You need to check at least that single pocket, because 96% of fetuses with fluid pockets less than 1 centimeter may be growth restricted. That's why you need to be very clear. And oligohydramnias, let's not be thinking very easily about it, that it is just some finding or the other. It will always precede lagging fetal growth. You may not even pick out a fetal growth restriction. There can be still oligohydramnias. Please keep it in your mind that it can also worsen as the baby grows. Asha, ma'am, what do you think? Can you summarize like the application of the biophysical test, and if you want to do the frequency of testing you would like to do?
I usually don't do biophysical profile. Only two things that I think are very important in that. One is the NST, which is there, amniotic fluid volume, and the fetal
modified.
The rest of the things really it is cumbersome, and I don't believe in that.
Yeah, the modified biophysical profile is the one which you would like to do, and because that's much easier, and the follow-up is also much easier.
Because by the time tone is gone, that means fetus is almost about to go. So why are you waiting for such a long time?
And CTG, ma'am, NSTs, how often will you do?
CTG, I do believe in CTG, but nowadays with good Dopplers,
I mean to say the frequency with which we were doing CTG has gone down, though it is a complementary thing. But if you have got good facility for Dopplers, and if you are, I feel all the obstetricians who are practicing high risk obstetrics should be doing their own Dopplers. So if you are good at that, then you don't have to do CTG that often. But yes, it does have its value, and especially in the night time and odd times when you have to do CTG, and it's still a good form of monitoring. But not as means maybe I think 10 years ago we were all the time dependent on CTG, but nowadays we are more dependent on Doppler findings.
And
Ma'am, I want
to. Yes, please.
Ma'am, in my clinical practice, I have seen that color Doppler was normal for past 3-4 days. Even a patient came 2 days back, she had normal color Doppler, and today she came for follow-up just to show me the ultrasound. She had less fetal movements, and I went for the CTG. CTG was non-reactive. Went for cesarean section, and it was meconium stain. This happened 4 to 5 times in my 3 to 4 months. This happened 3 to 4 times. So I usually just take this CTG as a very good mode of surveillance for these late FGR patients.
How is your sonologist?
Yeah, he was good. We can finally dependent on.
Depends on
your
sonologist.
Yes.
Okay. Because 4-5 times he is missing a baby which went for meconium is a little higher thing, because CTGs can pick up, but they are when you're having a Doppler and it tells you the correct picture, CTG will be only an add-on usually. So a non-reactive NST can happen in so many times, and we have found that the babies are perfectly doing fine.
And Dopplers, and you do Dopplers in those patients, and Dopplers are perfectly fine, and you leave the patient and things they do well. So yeah.
Ma'am, can I say something?
Yeah. Dr. Ruchika wants to.
Yes,
so as a sonologist, she wants to object to that. Okay.
Yeah, since we have two categories now, early onset fetal growth restriction and late. Here we need to understand those which are early onset. In those cases, due to high umbilical artery resistance, there is a more overwork by the heart. So the Dopplers will become abnormal earlier than the fetal heart rate changes. The CTG, they will show changes later on, but the Dopplers will show changes early. And in late onset, the brainstem is more sensitive to hypoxia. So in these cases, Dopplers may be normal, or CP ratio may be altered, or the CTG may be abnormal, or biophysical may show changes earlier than Doppler. So Dopplers can be normal in late onset IUGR.
Late FGR.
How will be the middle cerebral artery picture at this point?
Ma'am, that does not play any much role, because in early onset we know there is centralization of flow, brain sparing, so the sequence is changing. But once there is brain sparing, it is not going to help us in any way. So once umbilical artery resistance is high and then absent, then we have to switch on to the venous Doppler, the Ductus Phenosis, to further monitor for early onset.
No, Sangeeta's patient she was having absolutely normal Dopplers, and then she had.
Was it late onset FGR?
It was late FGR.
Yes, this is very important. They can have stillbirth, so we need a scan, one at 32 to 34 weeks and another at 36 to 37 weeks, because these are the ones in which placental damage is very, very less. So they may show the growth restriction very late. And even Dopplers may remain normal. Umbilical artery will have absent flows only when placenta is more than 60% damaged. When it is mild placental disease, like 10 to 15% only, so the changes in Doppler will not appear, but the fetus is growth restricted.
How will I pick up this baby that is going, because I cannot go for an early delivery without an indication there. So what should I
in these cases, late onset, we have to do, that's what I'm saying, that at 32 to 34 weeks one scan, and then 36 to 37 weeks once growth scan with Doppler is required. It may be that that growth restriction is shown later on, at the later part.
What is that risk factor which I need to know before I go for a screening for her twice? Because I cannot ask her to go for a Doppler twice without an indication there. So
no, ma'am, this has to be. See, at 32 weeks, if you are finding that it is growth restricted, so are putting into late onset. So once it is a late onset, we have to screen at 36 to 37 weeks also. We have to perform one Doppler at 37 weeks also.
No, Dr. Richa, that means we have already diagnosed growth restriction at 32 to 33 weeks.
Yes.
That's why we go. Suppose there's no growth restriction at 32 to 33 weeks, or
then
how
CP
much of
ratio.
restriction should...
Cerebroplacental ratio, it may get altered even if your umbilical artery Doppler is normal. It becomes less than 1.
Okay.
So we have to follow.
Yes.
We are talking about all the tertiary care centers you are talking about. Doppler can be done, CTG can be done. What about the majority of the rural patients we are dealing every day? And we have been taught by our seniors that heart is the last to go, FHR is the last to go. So if we depend,
see, now we have categorized early and late, so the mechanism is different in both of them.
Now we have got at the most 3 we are getting it done, and we come to know at 20-24 weeks only that this patient will go into, and 32 weeks the late FGR we are missing out. Most of them go into SBs.
Yes, late FGRs are difficult to diagnose. Yes, late FGRs are difficult to diagose, definitely.
So Charmila, want to know.
Depends on the Sunny Bhagavan. Depends on Sunny Bhagavan for you that day. That's what is the final this thing. Otherwise, you have to keep on because what she is saying is you cannot pick up a properly growth restricted baby at 32 to 33 weeks. You will have only a suspicion with your CP ratio.
Yes.
So you need to have a very good
increase your surveillance. Yes.
So the patient has to shell out lots of money for this. She has to be ready for that. Otherwise, you have to tell her without those repeated scans, we cannot pick up that late FGR.
Yes.
And that's the reason.
They are going to miss and they'll end up in stillbirths.
Yes.
Ma'am, still the
Yes, Sangeeta.
Yes, still the DFMC, daily fetal movement count, gives us a very good right.
That's ma'am, because it is the brain stem which gets hypoxic in late FGRs, and your daily fetal movement count, if it is normal, then it indicates that your brain stem is not hypoxic. And secondly, this biophysical profile also, the breathing movement biophysical profile also indicates that because the respiratory center in brain it is intact, so brainstem is not hypoxic. In term fetuses, it is the brainstem which is more sensitive. So we have this indicates that biophysical breathing is okay. We can't do the complete biophysical, at least breathing we can see. So it is reassuring that breathing centers are going fine. So late onset are difficult to diagnose. Definitely they are quite difficult to diagnose.
Madam, any suspicion, deliver at 37 weeks.
Yes.
True. Definitely. Definitely.
Steroids are there.
Okay. So the guidelines is SMF guidelines for NST is weekly NSTs after viability to just, as Dr. Ruchika said so clearly, you need to know whether there's hypoxia happening. So weekly NSTs can be done. Increased frequency, suppose there's Doppler abnormalities or there are other clinical indications like she's becoming severely hypertensive. So you may need to increase the frequency of NSTs or CTGs. And they have said about biophysical profile very clearly that they need further studies to prove the usefulness of biophysical profile, as Dr. Asha said so clearly. So biophysical profile at this point of time, you need not break your heads on. You can just do a modified biophysical profile and get away with Dopplers, because that will help you much better. So Dr. Ruchika, regarding the Doppler studies, because Dr. Kuldeep has said, so please summarize for us easily so that we keep it in our minds always. Otherwise, we need to mug up all the time.
Yes, in early onset FGRs, first there is increase in the umbilical artery resistance. This keeps on increasing till the point it reaches the absent. At the same time, there is, because of this high resistance, the heart has to work more. So, there comes the role of venous Dopplers, the Ductus Phenosis. It then, which is usually a triphasic M-shaped graph, it starts showing the changes. This is critically important, like in those fetuses which are less than 30 weeks, and we need some time so that they can reach to 32 weeks where the chances of survival are better. So in those cases, we need to follow with Ductus Phenosis. And in those which are late onset FGRs, in those cases, apart from the ultrasound, as I have told, at 32 to 34 weeks, repeat one at 36 to 37 weeks. And in these cases, placental disease is much less, so they are difficult to pick up. Okay. And CP ratio, the cerebroplacental ratio, it is more sensitive than middle cerebral artery Doppler alone, because they can pick up the changes earlier than MCA. And MCA, middle cerebral artery Doppler, is, it will just show that there is centralization, and, fetus is compensating, it is able to manage in utero, but it will not be helpful in surveillance. For surveillance in early onset, we require umbilical artery and ductus venosus, and in late onset, we have CP ratio, biophysical, especially just see for the breathing movements, and definitely CTG and daily fetal movement count.
Yeah, perfect. So now I've got an idea, like before and all, they used to say when you're getting your child married, an obstetrician getting married to a pediatrician is very good. But nowadays, I think you need a sonologist also. So you keep your child
Today is the era.
So
it is not obstetric ultrasound now, but it is ultrasonographic obstetrics now.
Yeah, that's what. We have been taken over by machines now. Dr. Sachibala ma'am, I think we have to close practice now, because we are sitting with the ultrasound machines. So the sequence, as Dr. Ruchika said so clearly: placental insufficiency, decreased nutrients, the preferred streaming to the heart compared to the liver. So there's more of effort by the heart also now once growth restriction starts. Abdominal circumference decreases. There's a reduction in the umbilical venous flow, which they say is a first hemodynamic change. There's an increased resistance in the umbilical artery, and that occurs because of the increased resistance in the placental vasculature. So the Doppler changes, as she said, if there's 30% damage, there will be an umbilical artery increased resistance. Suppose there's a decrease in the end diastolic flow, that means there's almost a damage of 60% now, which can be absent end diastolic flow or a reversal. Then that means 60% of the vasculature of the placenta has become resistant. So the early response is the compensatory responses, that is, the diastolic flow is still there. It is not, it become absent or reversed. There's a decreasing in the middle cerebral artery impedance, the redistribution of the cardiac output with a brain sparing effect. So actually, as she said, the growth delay is almost preceded 2 weeks before by a CP ratio. Please remember that the sonologist has to pick up. Cardiac function is still normal. Okay. Cardiac function is still normal. Hypoxia can be present, but there's no acidemia. And the brain changes will be picked up by the cerebroplacental ratio. That means the umbilical artery vasoconstriction versus the MCA vasodilatation. If it's less than 1.08, it becomes pathologic. And late FGR, as Dr. Ruchika said, can have abnormal MCAs without umbilical artery changes. But she said the CP ratio will be changing compared with the umbilical artery resistance, which may not be seen because of the lesser damage in a late FGR baby. So this is what MCA means. It means a cerebral Doppler is useful up to 32 weeks. And that's why she said it's very good for late FGR compared to the early FGR. If it's normal, you repeat after 2 weeks. If it's abnormal, you need to check it weekly. Late response, the decompensation changes, where there's absence of end diastolic flow or reversal in the umbilical artery. And as she said, the venous flows become very important to know the cardiac work of the baby, like the ductus venosus, the inferior vena cava, and the umbilical way. And oligohydramnios is also a decompensatory mechanism by the fetus. And the venous Doppler changes are very ominous because they predict stillbirth, and the ominous changes or the absence or reversal of the ductus venosus wave or the presence of umbilical venous pulsations. And this mandates increased fetal monitoring if the baby is small, and you need to wait for a period of time before you deliver, or like giving steroids and then delivering. So regarding the other surveillance tools, Dr. Ruchika, as you said, CTG should not be used as the only form, but you can add on to your Doppler testing. Interpretation should be based on a short-term fetal heart variation, and that's very much better picked up by a computerized analysis compared to the other methods of visual examination. And ultrasound assessment of amniotic fluid volume should not be the only form of surveillance in SGA fetuses. And now at this point of time, a single measurement of the single deepest pocket is accepted as a good amniotic fluid volume. Sachibala ma'am, suppose this patient is affording, how often will you screen up with Dopplers? Somebody is disturbing in the middle, Deepika. I don't know. Can they be muted? Meera ma'am's this thing, I think. Kiran ma'am, can you ask madam to mute? Lots of disturbance from there.
Ma'am, I'm just checking.
Okay.
No, Dr. Meera, it's not from Dr. Meera.
Okay. Okay, now it's better. It's gone. It's gone now. Dr.
Yeah.
Sashi ma'am, optimal frequency of Doppler screening.
See,
Suppose it's a normal. We have talked all about this. I just want you to recap. That's all.
So we are talking about early or late. So now,
no. This is just FGR. We don't know whether it's early or late. Okay. All are normal. Umbilical artery Doppler is normal. We are very happy now.
So
everything.
weekly,
So what will you do?
see, weekly testing of if she can afford it, then we can have weekly testing of umbilical artery Doppler, and biometry we can have once in 3 weeks, and monitoring is done just to identify. So identification is more important, and then that depends on whichever is needed. Can you hear me?
Yes, ma'am. Yes, ma'am. It's audible.
Yeah.
Okay.
Yeah.
Suppose it's an abnormal umbilical artery Doppler. When will you call her back?
Then, as you said, every 14 days, twice a week. Sorry, twice a week we'll call her if it is abnormal, and we have to see the diastolic velocities, and also not only we'll see for the ductors and all, we'll also see for the aortic, as sir has said. We'll see for that. For the left heart goes first, then the right. So
I differ a bit. In cases there is decrease in end diastolic flow, you can have 2 weekly ultrasound, and once it is absent, you can have twice weekly.
Twice weekly is absent.
Once it is absent, even in absent, we can have twice weekly. Daily for reverse, I'll go for daily.
Daily, okay.
The reverse is more important. No, reverse
I'll go for daily.
You would have admitted her when she's having a reversal of flow, because you need to give her steroids and then deliver her within at least 48 to 72 hours later. But for an absent diastolic, absent diastolic flow, Dr. Ruchika is saying you can wait for like twice weekly is enough. But I will just put up the guidelines of SMF which has come in 2020. Dr. Reena, this we have covered already. I would like to recap on that. What is the difference in monitoring in Dopplers in an early and a late FGR?
Well, as we have already discussed, that in early IUGR is a compensated baby, a baby who's used to hypoxia, and a late one is the one who is sensitive to hypoxia. So frequency of monitoring will be more with the late FGR as compared to the early FGR. It will depend on number one, what is the severity of the Doppler. Like if only the umbilical artery Doppler indices are raised and we still have the end diastolic velocity, if we go for, say, in early FGR, we may go for twice after 2 weeks, but in late FGR, we may have to do weekly Dopplers. Then if the end diastolic
can I ask Dr. Ruchika to comment on that? Because she said differently.
Yes, ma'am. In early onset, if there is FGR and there is high resistance in umbilical artery, we can go for two weekly Dopplers are enough. If it is absent, as I told you, then we have to increase the frequency. Otherwise, we can go for even if
it is reversed.
Yeah, definitely.
Dr. Reena said that when it's late FGR, she will go for frequent testing.
Yeah.
Is that right compared to early FGR?
For late FGRs, ma'am, they are, as I told, at 32 weeks, we diagnose it. We can go for weekly. Yes, we can go for weekly. No harm in it.
So
because they have to be under surveillance.
Yeah, the surveillance has to be more frequent for the late FGRs, because
how frequent? Like she's saying, like once a week, if it is going to be presence of end diastolic flow still, even then there's a reduction.
Yeah.
And when it's absent, she said twice in a week. And when it's reversal, she'll do it daily. And in a late FGR,
the patient.
Yeah, but in a late FGR, how is it different? I'm saying.
No, this is for the late FGR. This is what you said.
Sharmila, it's all getting confusing now. Can you please explain?
Yeah. In early FGR, if there's going to be an abnormal umbilical artery Doppler, that is, there is the umbilical artery Doppler end diastolic, that flow is going to become reduced, but the flows are still present. It is not absent or it's not reversed. It's still there, but it's reducing. So the end diastolic flow is coming down, but there is still presence. Then you need to repeat your Dopplers once in a week.
Okay.
That is okay, Dr. Ruchika? Or there's a
There
change?
are so many algorithms and so many guidelines, and all guidelines are not
because we don't
yeah, that's what
you tell us.
Yeah, but you differed with this. That's why I'm putting it to you, Dr. Ruchika, because they said twice weekly when the end diastolic flow is still present. It's not become absent. So twice weekly is the one which they say
it's very
the
frequent.
guideline.
Practically, it's very difficult twice weekly when end diastolic flows are already there. So I think it should be 2 weekly because still it's not absent. We are not that much worried.
Yeah, that's what I'm saying. Two weekly only I've said. It's only the same thing I put
after 2 weeks.
After 2 weeks.
No.
Why don't we go
after 15 days? After 15 days, you'll check.
15 days.
Yes.
After 2 weeks in early and after 1 week weekly in late.
Yes.
Ma'am, in
that
early
is the
you can go for.
Okay, the consensus I will tell at the last because there's a confusion there. In early FGR, late FGR, is there a change? Dr. Ruchika, I will tell, Sashi ma'am, we'll have a discussion at the end. I will tell you like what is the guideline is.
Yes.
Dr. Ruchika and Reena have to now tell me in a late FGR, how will I change my protocol? Because according to them at this point for an early FGR, they will do a umbilical artery Doppler once in 2 weeks if there's going to be a presence of end diastolic flow still, even if there's a reduction. That is, they feel that the baby is still going on fine. Suppose there's going to be an absent end diastolic flow, they will do it once in a week, right?
Okay.
Dr.
Twice
weekly. So from 2 weeks she's coming down. Yeah, from 2 weeks she's coming down to in a week twice for an absent end diastolic flow. Suppose it's a reversal, she will admit and do daily. That's what they're doing for an early FGR. Suppose it's late FGR, how will you change your protocol?
Ma'am, for late we are doing weekly. I'm following weekly.
That is for a presence of end diastolic flow. That is, there's still no absence.
Because in that umbilical artery may not show changes. We have to be more careful for the CP ratio.
CPR.
CP ratio.
So your protocol for your protocol in a late FGR will be weekly Dopplers along with your CP ratio. That is weekly umbilical artery Doppler with cerebroplacental ratio. Sashi ma'am, that is what they will do for late FGR.
Late is clear. Late is clear.
Suppose absent or reverse, we would have delivered, no, because she's late FGR. We will not wait for anything. That's
late
what the
is
protocol.
Dangerous. Yes.
Now it's clear. Okay. So that's a guy. The final this thing we will come to the point in our last this thing. Okay, Dr. Sachi ma'am. Okay. Dr. Reena, you said very clearly on that. So we are accepting that. And delivery in late FGR. Can I ask Dr. Sangeeta?
Ma'am, we have to. In the late FGR, we have to be carefully follow the labor. We have after 37-38 weeks, depending on the umbilical artery end diastolic flow is present or absent or is reversed. We have to do the surveillance along with continuous CTG monitoring. We have to induce the labor.
So you're going to go for a normal delivery for vaginal delivery, giving her a trial.
If there is no contraindication, usually in our clinical practice, we usually when we do the prognostication to the attendants and the patient, usually the rates of cesarean sections are more. But according to the guidelines, there is no.
I want to know what you do in your practice. Like what is that baby you take for a cesarean? What is that baby you'll ask to go for a vaginal delivery?
If it is a late FGR along with umbilical artery and CP ratio is normal, less than 5th percentile, more
that
than
is only
CP
growth
ratio,
restriction with no vascular changes.
No vascular changes.
I'll
go for vaginal delivery along with continuous CTG monitoring. If there is any absent end diastolic flow or the reversal, I'll definitely go for cesarean section.
Okay. And how long will you wait to deliver a late FGR? If it's between 3rd and 10th percentile, you need to deliver at 38 to 39 weeks. Even if your umbilical artery Doppler is normal, please remember, even if umbilical artery Dopplers are normal, but the baby is growth restricted, you wait till 38 to 39 weeks and deliver her. Suppose it's below 3rd percentile, even if the umbilical artery is normal, you will deliver her by 37 weeks of gestation because this is a severely growth restricted baby. If there's a reduced umbilical artery flow without that is like no absence or reversal of diastolic flow is there, then at 37 weeks you will deliver. If any time you have absence or reversal, you will deliver her because already she is crossed the 34 weeks. So anytime she will be delivered if you have got her absence or reversal. There's no point in monitoring the CTGs trying to prolong because the baby is already attained maturity. It will do much better in your NICU compared to inside in utero. So Dr. Sangeeta, so the difference between SGA and FGR, which is just an SGA baby and which is an FGR baby?
Basically, SGA is the effective fetal weight is less than 10th percentile. And if it has got more any of the Doppler findings which are like unlikely, that is additive to the SGA, it is the FGR. Or by other definitions, SGA is less effective fetal weight less than 10 percentile. FGR can also be that. We have to follow this SGA 2 weekly to see for the Doppler changes. If any of the Doppler changes come, this is the FGR. Or the effective fetal weight is less than 3rd percentile. We have to take it as the FGR.
All this came in the questions of Dr. Kuldeep.
Yes.
You remember? So clearly put it there. And there's a pathologically growth restricted baby is a less than 3rd percentile baby and has got an abnormal umbilical artery Doppler. So the third patient, she's 40 years, regular cycling patient, married since 20 years, known hypertensive, has conceived with IVF donor egg. What's the surveillance protocol for her? She's really obsessed with all the medical things because already 20 years she has undergone some treatment or the other. She'll actually run the clinic for you. Prevention of SGA. She's asking, I don't want a growth restricted baby. What can I do? Dr. Rashi, can you help us? Dr. Rashi?
We'll start aspirin.
Okay.
Hello?
You think it works? You think it works? Rashi, we
Yes.
can hear you. You think it works? When will you?
Yes,
when will you start? When will you start?
We'll start since beginning.
You
When
have
we
to give
prepare
us,
the endometrium, we start from that point on.
I will ask Kiran madam after a year. You'll have to give us data. How many babies you give aspirin and how many prevention? Okay. We'll have good data from, because we'll do a study on that. We need data on them. Actually, it's very good, we know, but we are not putting up data to say how useful it is. That's why I said. So aspirin is the drug you try, then?
We can,
anything else?
In practice, we start PDA5 inhibitor also. And
it works, Rashi?
It is also.
When do you start?
Like phosphodiesterase inhibitor also. And it is also like useful, I feel. And
when do you start? Because youngsters have to teach us now. When do you start?
Ma'am, I used to start with the like embryo transfer only. And once if she is his risk factor, like she is hypertensive also, I used to give it from like before ET, I used to start this.
How many weeks will you give? Up to how many weeks of pregnancy you give them?
Ma'am, I used to give till 12 to 14 weeks.
But your definitely your pre-eclampsia rate and growth restriction has gone down with both sildenafil as well as aspirin.
Ma'am, I have very less experience and it's like
because every IVF center they give a cocktail. Masala, every masala. They give aspirin, they give 3 forms of progesterone, they give sildenafil, they give Preg because arginine, because they say it's a nitric oxide donor, so that will reduce oxidative stress and all that. But in spite of all that, IVF babies have got the maximum complications. Suppose we have not given all that, probably they will have a much better. I will ask Asha ma'am if she is there. Okay, so the prevention, we know it's disappointing. Eliminate stress, smoking, alcohol, drug abuse. Those are all known factors. Adequate diet, maternal hyperoxygenation, alimentation, all that is useless. Volume expansion with IV fluids has no meaning at all. Low dose aspirin, as Rashi said, may be useful. Low dose aspirin is definitely proved, and they say when you give it at a higher dose of 150 milligram, it works much better. And there are studies now which tell this is very useful. Corticosteroids only for fetal lung maturity, which is below 34 weeks. Otherwise, it's not used for prevention of FGR. How about heparin? How many use heparin to prevent FGR?
It looks up.
Ma'am, if the antiphospholipid antibodies are positive, if there is any risk factor, then only an oxygen.
Not useful. Not useful.
Dr. Sangeeta, you give?
Ma'am, I don't give.
Sashi ma'am?
No, I'm not giving, but here in Gwalior, I have my seniors are giving. So heparin is there, yes.
Yeah, we'll bring out a data collection now to see what's happening in the country. Dr. Ruchika, you think any drug is useful to prevent FGR?
Ma'am, definitely Ecosprin 150 milligram is helpful, and Fetal Medicine Foundation recommends it before 16 weeks to be started for prevention of FGR as well as preeclampsia. This is proven. 150.
Dr. Reena is there. She wants to add anything. Dr. Reena?
I'm 150 mg, that too in the evening. I found I could go for the reference, but I couldn't find the reason. But that too in the evening, that gives the good results.
At how many weeks you start?
Before 16 weeks.
Okay. So
in this case, one should start before implanting.
Before conception, yeah.
Arginine helps, I've seen.
See, new drugs will come. Okay. So Dr. Asha ma'am, what are the types of growth restriction? We were talked so much about that. Madam is there. You think you believe in symmetric and asymmetric FGR? She is there? I think she's left.
I think
Dr.
she's left.
Dr. Sashi ma'am, can you tell us, do you believe in asymmetric and symmetric FGR?
Asymmetrical, symmetrical is only we discussed when actually the asymmetrical first when we were studying, and nowadays they are not going in for asymmetric and symmetrical IGR because eventually the treatment is same, monitoring is same, so it doesn't help much. It only we just notify that this is asymmetrical or symmetrical. That's how. So it depends on the placenta.
We read this in areas as postgraduates, so that's why I put up the slide. The pattern of sequential growth of placenta and fetus, it can be cellular hyperplasia followed by hyperplasia and hypertrophy, and then it will be just hypertrophy in the final stages. If there's a disruption at the hyperplasia stage, it will cause symmetric IUGR. Placental disease usually will cause asymmetric IUGR, but it can be symmetric as the placental disease becomes worse. The patterns can be asymmetric or symmetric. Some asymmetric is where the abdominal circumference and the lower body shows a difference in the growth and the sparing of head growth. Symmetric is both are affected similarly, body as well as the head growth. The pattern will depend on the underlying cause, timing, and duration of insult. Suppose the insult happens in early pregnancy, like an infection, aneuploid syndrome, or anything like that, it can cause a symmetric IUGR. That's why you need a proper examination of such fetuses to rule out all these problems before the baby grows. Because if it's very severe, madam, there's a big disturbance from somewhere. Yeah, it's better now.
Malaria is endemic here, so we get a lot of
symmetric
malaria. Yes.
Yeah. So very severe, it can cause even abortion or early stillbirth. And suppose the adaptive mechanisms have permitted the growth of the baby, there will be ongoing survival, but there will be evidence of FGR later on. When the baby has survived the insult, but it's still growing, it is one of the causes for symmetric FGR. And Dr. Sashi ma'am, the risk factors for early FGR. So these are the ones, and she said malaria is a big part in some parts of the country. And we know maternal causes now. Every lady who comes has got hypertension now, diabetes now, everything they come with. So almost all our mothers are at high risk. And suppose she's exposed to a teratogen, there's an infection, there's a genetic disorder, all this can lead on.
What about COVID now? No studies as yet, no?
Not yet common, but they're saying it is causing more of FGR. It's causing more of FGR. Because it's just a year, no? So we'll know in 1 or 2 years what type of delivery is.
The trait is it is a viral and anti-inflammatory, so naturally.
Because we are seeing more of deliveries are very common. And I'm seeing some stillbirths also. That's also more.
Even dengue is also.
Yeah. Dr. Reena, how to? Yes, ma'am. So how to evaluate early FGR, Dr. Reena?
Yeah,
we've already talked about it, but for early FGR, I just wanted you to point on the very early FGRs, which can happen
early FGRs because we have said that they are usually associated with anatomical abnormalities or chromosomal abnormalities or infections. So we'll have to find the cause also, and at the same time, we'll have to go for our ultrasound and Dopplers also. So for chromosomal anomalies, we may go for early FGRs for amniocentesis and do the karyotyping, and by FISH or by these days we are doing the microarray, And for infections, we'll do the serological survey of, say, Toxoplasma, CMV, rubella. And in our area, we will test for malaria and syphilis also. And we'll do the viral.
But syphilis, most of us do it routinely, no? So
yeah, we do it routinely, but some people have stopped doing it. I'm doing it routinely, but some people are doing VDRL. So in these cases, at least we will have to do. Then, of course, the TIFA scans, the routine TIFA scan by an expert fetal medicine specialist in this case. And then we'll have to do workup with the Dopplers, as we have already said, for further surveillance.
Yes, ma'am. Yeah, thank you. So these are the ones which you mentioned already. So Dr. Sangeeta, do you think Dr. Sangeeta, do you think a uterine artery Doppler screening at 20 to 24 weeks, which we do for the minor markers, is needed for a high-risk patient like this? You think it's useful?
Yes, ma'am. It is useful. We should go for it.
Yeah, but actually it is not indicated as for a low-risk patient, because high-risk patient.
Ma'am, you have written high-risk patient.
Yeah, because for a high-risk patient, already you know you're going to put up your surveillance protocol from 26 to 28 weeks onwards. So just by doing a uterine artery Doppler, you're not going to change your protocol. That's what I meant. Just to add another test, suppose she's from a very poor place or something, just do an uterine artery Doppler to find out if she goes to FGR. It's not useful for a high-risk patient. That's what I meant. Okay. Dr. Sangeet? Okay.
Okay, ma'am. Okay.
It is recommended for three minors. If there are 3 minors.
Three minors. This patient is very high risk, no, Reena. She's already having a age of above 40. She's like a IVF pregnancy and all that. So
we can see ma'am. We can see the uterine artery like notching. We can also see the
first trimester.
Because when you are giving so many drugs for an IVF patient, doing an extra scan is not going to be wasted. She will spend for that. So I'm just saying, suppose she's just a person who's already having a high risk factor, doing a uterine artery Doppler will not add on to your protocol. That's what I meant.
Done.
So the major risk factors, Dr. Sangeeta, can you summarize? Because you already talked about it. I'd just like to tell you about this.
Should I read it?
Yeah, please read.
It needs intensive surveillance. Ideally should be started from the 26 to 28 weeks of the pregnancy. Serial ultrasound measurement to see the fetal growth. Serial fetal growth is to be seen, and assessment of the umbilical artery Doppler. And if it is required in the early, if we are assessing for the early less than 32 weeks, we can add upon the Ductus Phenosis parameters also. If it is in the late, after 32 weeks, we can add upon the umbilical artery, the cerebroplacental ratio along with MCA.
So this is what the pathway is. The algorithm is, suppose the estimated fetal weight is less than the 10th percentile, you have labeled her as either a SGA or as a FGR. You will do an anatomical survey as well as an amniotic fluid volume, because we need to know whether she has got any aneuploid syndromes, any anomalies, the polyhydramnios, because of an anomaly also, and you have to rule out aneuploidies and viral infections. Suppose the baby has got a normal anatomy and the amniotic fluid volume is normal, you will do an umbilical artery Doppler as well as an MCA Doppler, because the baby is growth restricted, less than the 10th centile. You will do a cerebroplacental ratio. If it's normal, you will proceed on to examine the mother only after 2 weeks if everything else is normal. If this is normal, the growth velocity is maintaining at less than this 10th centile with no Doppler changes, the baby is labeled as small for gestational age or just a constitutionally small baby. But if the cerebroplacental ratio becomes abnormal, there's a decreased ratio, then you need to do further testing with the umbilical artery Dopplers, and your frequency of testing becomes much more when you pick up any abnormality in the umbilical artery, the MCA Dopplers, or in the cerebroplacental ratio. And when you have got an elevated index or an absent or a reversal of end diastolic flow, which along with the brain sparring effect, it becomes a FGR baby. This is what the algorithm for management of FGR is in our country at this point of time. So that will be for Dr. Ruchika. So the surveillance tools in early FGR, now you have to tell us very clearly, because Dr. Sashi and myself were a little confused about this still.
In early onset FGR, we will look for the Dopplers and After the growth has been done, we look for the Doppler. Some umbilical artery Doppler is the, in this we have to see for the three indices, the systolic upon diastolic ratio, resistivity index, and the pulsatility index. Out of this, the pulsatility index is the most useful because it always gives us a value and it is never infinite in like resistivity index. So with increasing resistance to the flow, when there is placental disease, so there is increase in the resistance to flow in the umbilical artery, which will be shown with decrease in the end diastolic flow, in the diastolic flow in the Doppler. So as this resistance keeps on increasing, the diastolic flow will keep on decreasing, and to a point that fetus is compensating in utero. What will the fetus do since it is getting less of blood flow? The abdominal circumference will decrease, and it will spare, it will preferentially send the blood flow to the brain, the kidneys, the adrenals, and brain, adrenals, and the heart, and it will decrease it to the kidney. So due to decrease in the blood flow to kidney, it leads to decrease in the LycoRed, and decreased blood flow to the abdomen or the liver leads to decrease in the abdominal circumference. So this continues further and further to the point that there is an absent end diastolic flow. And the preferential blood flow to the brain leads to changes in the middle cerebral artery Doppler. So there is decrease in the pulsatility index in the MCA, or there is reduction in the cerebroplacental ratio. And at a point comes when there is absent in the end diastolic flow in umbilical artery. At that point, if the fetus is more than 32 weeks, then we are not that much worried, because the survival, it has a better survival outcome ex utero also. But if it occurs before 32 weeks, then we have to resort to the venous Dopplers as well, because we need time so that we can push this pregnancy further few days more in utero without compromising the fetus in utero. So for that, we have to do the ductus venosus Doppler. In ductus venosus Doppler, we look at the waveform. There's S, D, and A wave. Basically, we perform the venous Doppler of this, where we look for the pulsatility index in the ductus venosus. This will keep on rising to a point of more than 95th centile. And that means that the blood flow or the A wave keeps on decreasing to the point that finally it will be absent, and then it will reverse. So before 32 weeks, we can wait. But more than 32 weeks, if that is absent, then we can give the steroids and think for delivering. But before 32 weeks, we have to wait. We have to perform the venous Dopplers. Between 28 to 30 weeks, we can wait even till ductus venosus reversal also, because the baby is so small. If we give a 28 weeks baby and we deliver it, it is more at risk ex utero. So till 30 weeks, we can wait till ductus venosus reversal also in utero. And after 30 weeks to 32 weeks, if there is reversal, we have to deliver. But after 32 weeks, if it is absent also, we have to deliver.
You have to deliver. Yeah, perfect. Because this, we have to be very clear, because in a preterm FGR, there's no role for biophysical profile. It's only, as she said, your venous Dopplers only will tell us when to deliver the baby. Middle cerebral artery Doppler also has got a very limited accuracy in preterm FGR. Ductus venosus Doppler should be used for surveillance in a preterm SGA fetus with an abnormal umbilical artery Doppler, and that will help us to time the delivery for the fetus which is growth compromised. So Dr. Rashi, we would like your opinion on the delivery of these babies.
Ma'am, in this case, if she is between 30 to 32 weeks and there is reversal, I will deliver, because she is precious baby, IVF baby. She's 40 already, hypertensive, and if she crosses 33 and she is less than 34 and there is absent, I'll deliver. And after 34, it is like
any chance of normal delivery, Rashi?
Very rare, apprehensive.
Yeah. Somebody they want to close the IVF center, they can take a risk with vaginal delivery. Okay. So, and Dr. Ruchika said very clearly, steroids need to be given when you're anticipating delivery before 34 weeks.
Before 32, magnesium sulfate is also.
Yes, Rashi. Magnesium sulfate, if you're going to anticipate delivery in the next 24 hours, you need to give a magnesium sulfate for the neuroprotection of the fetus. So this is what for Dr. Ruchika, the googly, to diagnose very late FGR. You need to clear our doubts on that for me and Dr. Sashibala, ma'am.
Yes, ma'am, they present later on because the placental disease is less. So the manifestation in the fetus also appears later on only. And so routine third trimester ultrasound between 32 to 34 weeks is a must.
I'm asking you this because the guidelines are telling us there's no point in doing any biometry ultrasound after 34 weeks of gestation. That's what they're saying.
Nothing like
but
this.
We know, yeah, but we no, the guidelines are saying there's no point in doing after 34 weeks for biometry scan with a Doppler because they're saying it's not useful at all. But we know practically that when you do a do an ultrasound in the late trimesters, you can pick up those babies which will go for stillbirths. Because even if it can be one out of like the deliveries in a year, still it matters to the mother. So if she can afford it and she can do it, we have to repeat an ultrasound after the 34th scan just to check out whether the baby is growing on well. If you want to keep her till term, because we don't know who are the mothers who are going to go for a problem. And when you have an unexpected stillbirth, and that too with such high risk IVF mothers, I think it's mandatory. Even if you have got an normal umbilical artery flow, please check out with an ultrasound. At least around after 32, it should be around 35 to 36 weeks just to pick up this late FGR.
So here, I just want to add one more thing. Like if at 32 to 34 weeks, we have measured the weight or the AC, and at 36, 37 weeks, there is fall in the percentile of this by 50 percentile. Even if it is not falling in, there is no Doppler abnormality, then also these fetuses are at high risk. Fall in the percentiles.
So there's
the abdominal circumference or the estimated fetal weight. Suppose from 80 they have come to 30th centile, you know, the abdominal circumference or the estimated fetal weight. Even they are at risk for such events later in pregnancy.
Reena, what do you want
to
say?
Extension to what Dr. Ruchi said, that in late FGRs, usually in FGRs we say that we should not rely on a single factor. We should always take multiple factors into consideration. But in late FGRs, it is said that even if there is change in any one single factor, like if only the AC is decreasing or only the Lycor is decreasing, or any change only in the umbilical or only in the CPR, we should take it seriously.
Yes, we have to intensify the surveillance.
Sashi ma'am is there, ma'am? Sashi ma'am? Sashi ma'am, you're there? I think she's left. Okay, I just wanted to clear the doubt which she had regarding the late FGRs, which needs to have a separate protocol. So the take-home message is optimum method, as we all agreed, is either the abdominal circumference or the estimated fetal weight, which is less than 10th percentile. Biometry needs to be done every once in 3 weeks. You need not repeat it again and again. But if there's a low growth velocity, you need to go for an umbilical artery Doppler for your surveillance. And this is the guideline, this is 2020 guidelines SMFM. And what they've said, suppose it's a normal flow, umbilical artery Doppler once in 1 to 2 weeks. And as you said, 2 weekly, that is quite correct. Once in 15 days, you said, Dr. Ruchika. So that is quite correct. And if you want to do it a weekly also, if she can afford it also, it's okay. That is what the guideline says. But suppose it's an abnormal end diastolic flow, but there's a decreased flow, you need to go for a weekly Doppler. Weekly Doppler is needed. And if the flow ratios, or suppose it's a very growth restricted baby, like less than the 3rd percentile growth restriction is there, then also you need to go for a weekly Doppler. Now you cannot do once in 2 weeks. Even if she's got a normal umbilical artery Doppler, if she's less than the 3rd percentile according to this guideline. Suppose she's got an absent end diastolic flow 2 to 3 times a week. Suppose it's reversal of the flows, you need to hospitalize her, give her steroids, perform your CTGs 1 to 2 times a day, and have a very low threshold for delivery depending on the clinical scenario. That is a final guideline in 2020 by SMFM. And the utility value of the different tests which you've already talked about, routine testing for, this is what I wanted to tell you, Dr. Ruchika. The guideline says, but this is for a low risk women. But most of the women who have unexpected stillbirths are the low risk women. The high risk women, we always take proper protocols. We manage them very early, and we give them a good outcome. But for the ones whom we presume, whom we think that they are low risk women are the ones who have these unexpected stillbirths. So it's worthwhile not following this this thing of not doing an ultrasound at around 36 to 37 weeks of gestation. It is justified because if there's any change in the fetal growth velocity, any one parameter which is changing, you need to take a call on that. You may need to go for much more surveillance to check out these babies. Uterine artery Doppler is of no use in the third trimester. That's very clear. Middle cerebral artery Doppler reports cannot be used to time delivery in an early FGR. Here you need to do a venous Doppler. MCR Doppler used in term FGR for timing delivery can be done because, as Dr. Ruchika said, the cerebroplacental ratios as well as MCR Doppler will be of little help there. Short-term variability in CTG is much better than only the reactivity for surveillance, and a computerized analysis is much better. Amniotic fluid volume is best based on a single deepest vertical pocket. Biophysical profile cannot be used as a single tool for surveillance. And regarding the other vessels Doppler study, SMFM tells us, Dr. Ruchika, against ductus venous Dopplers, middle cerebral artery Dopplers, uterine artery Doppler studies in earlier late onset FGR. These studies have not been found to lead to improved accuracy over umbilical artery Doppler. So suppose a sonologist or the obstetrician themselves are very comfortable doing umbilical artery Dopplers, they can still manage a FGR baby. And regarding the timing of delivery, suppose there's oligohydramnios, delivery should be between 34 to 38 weeks of gestation. Normal umbilical artery Doppler, but the estimated fetal weight is around the 3rd to 10th percentile. You can wait till 38 to 39 weeks if there's going to be a normal Doppler. But if the birth weight, the estimated fetal weight is less than the 3rd percentile, you cannot afford to wait till 38 to 39 weeks. You need to deliver by 37 weeks of gestation. Suppose there's a decreased umbilical artery flow, you need to deliver by 37 weeks. Absent end diastolic flow, 33 to 34 weeks should be your aim. Reversal, even 30 weeks is acceptable because you need to give a good outcome. And administer corticosteroids and magnesium sulfate for preterm FGR. And the mode of delivery, cesarean delivery, there's no strict recommendation just based on FGR. Reserve for usual fetal and maternal indications, but there's an absent end diastolic flow or reversal, you can go for a cesarean delivery. Mode of delivery, you can determine case-to-case basis depending on the clinical presentation and the maternal preferences. Thank you so much. I'm extremely thankful to all the panelists who did such a beautiful job. And I know we have taken up so much of our time. I hope it was, you gave us a good opinion and gave a good consensus to us. I think we'll all remember that. Thank you so much. I would like to thank each panelist.
It was good.
Thank you.
You enjoyed it?
Revised everything again and again, and we will do remember everything.
Thank you. Thank you, Doctor.
It was very nice.
Thank you,
Fantastic session, Doctor.
It has struck here.
Dr. Sashi ma'am, we cleared your doubt actually. We just wanted to tell you. Suppose that unexpected stillbirth usually happens in low risk, so-called low risk women. Because if she's got a high risk factor, we always follow them with care. But when there's a low risk women, we tend to think that she'll do normally, but 1 or 2 women out of the many will have a problem. So what the consensus from the panelists was, you do ultrasound around 32 to 34 weeks to check out the biometry. And suppose you feel that your instinct tells you that something is going wrong with your clinical estimation, after 3 weeks, it's worthwhile repeating an ultrasound. And suppose even one biometry changes or one Doppler change of minimal change is also there, please take a call on that, because you may need to do much more surveillance for this mother or deliver her early also if needed, because we need to save that unexpected stillbirth in the so-called low risk women. That's what the thing.
So no complacency, no complacency, even low risk.
Otherwise we have to leave obstetrics and walk off. Otherwise, that's the only thing which will make us survive.
Yes.
Thank you, Sashibala ma'am. Thank you so much for your contribution. Thank you, Dr. Reena, Dr. Sangeeta, Dr. Rashi, and Dr. Ruchika. You did a great job for us, and Dr. Asha Bakshi ma'am. Thank you so much. And I'd like to thank Dr. Kiran ma'am for the opportunity. Thank you so much.
Yes, Kiran, Dr. Kiran, thank you so much.
Thank you, Dr. Sharmila and everyone. Thank you, all the panelists.
Sharmila always drives home the message. The practical approach is always very good and very helpful, I tell you.
Thank you, Doctor. Thank you, Dr.
Sharmila. It was fantastic. Very good.
Thank you.
Nila,
thank you, sir. Thank you so much.
Thank you everyone. Thank you. And thank you, Dr. Deepika, also for always giving a nice technical support for all the webinars. Whenever I just give a call, she is always ready for me. Thank you so much, Dr. Chandra. Thank you so much, everyone.
Thank you, Kuldeep sir.
Thank you.
Thank you so much.
Thank you, sir.
Sir, I just like to add something. On behalf of Jagsonpal, makers of newly launched Algos Spas tablet containing Drotaverine and Mefenamic Acid, and calcium tablets from Jagsonpal, NAARI Cal, maintain 500-200 milligrams hydroxyprogesterone caprate, maintain tablet, Allylestrenol 500 milligrams, Divagest SR 300 and 200 milligram natural progesterone, LycoRed Softgel for pre-ecalmpsia IUGR, and also we have LycoRed Preg sachet, the L-arginine Lycopene DHA to prevent pregnancy complications. Myself, Amit Saxena, along with Dr. Deepika Chawla and Dr. Arvind Singh, join me to thank the faculty present with us today. We truly appreciate the presence of all the attendees. With your attending support, we hope to go a long way in knowledge sharing. We express our gratitude to attendees, panelists for participating, and we look forward for your presence in our next webinar. Thank you, ma'am. Thank you, ma'am.
कितने लोगों ने लॉगिन किया था, डॉक्टर अमित?
Ma'am,
278.
It was more than 300 plus, but after maybe it will go to around 500, 600. Let's see.
Thank you so much. Thank you, Dr. Neelam, for always giving me so much support to me for conducting each and every webinar. Thank you so much.